him. He's our Gordon Murray Lecturer, who is arrived from the University of Cambridge, the 41st annual Gordon Murray Lecturer. The symposium today has to do with trauma, neurotrauma, and Peter is a maven for neurotrauma in the world, and you'll hear about his accomplishments shortly. So with that, I'll turn the program over to Michael, who's got a few slides and has some things to say to you. But anyway, thank you all for coming to GallieDay and for your support of the Department of Surgery.
And a big thanks to you, Professor Rutke, for all of your support. And I think this may be the final GallieDay, so it's really great that we are doing this in person. And big thanks to Val and to Sylvia for accommodating my request to try to do this as a hybrid meeting, which is like double the work. So welcome everyone, and welcome to those also who are online. So we've called today's GallieDay, the Advances in the Art and Science of Traumatology from Cell to Community. And a subtext to this is, where have we been, where are we now, and where are we going? And I think that the last couple of years have really given us a lot of pause and reflection for this. So I'm a kind of a fan of Impressionist art, and in fact the theme of today's GallieDay is reminiscent of this painting by Paul Gauguin, D'où venons-nous, que sommes-nous, où allons-nous? And for those of you who are maybe not so good at French, where do we come from? What are we? Where are we going? And I think really this is kind of a pause for reflection. There's been a lot of lessons that have been learned over the last couple of years, but also tremendous opportunities for us to move forward. It's a great honor to have Professor Peter Hutchison, who really is a giant in the field of neurotrauma, and we'll have a more formal introduction later. But Hutch, thank you so much for making the trip across the Atlantic to be with us, and we look forward to your lecture later on rescuing the injured brain. So this is just kind of a reflection of today. We'll be having a number of talks from our trainees. We'll then follow with the Gordon Murray Lecture. We'll have an e-poster a presentation, a session, then a few remarks before we have lunch, and then we'll have a symposium in the afternoon in the Art and Science of Traumatology, some further oral presentations and e-poster presentations, and then we'll wrap up the day. So we've been trying to build in some breaks, also to be sensitive to the people who are participating online, because it's, as we all know, it's rather difficult to sit in front of a computer for hours at length. So Jim Ruck has already referred to the research committee. We have a fantastic research committee, very active. Again, to acknowledge Val Cabral and the other members of the research committee. Thought I might do just a little shout out to Bernard Langer, who sadly passed away this past year, and Bernie, who's a past chair in the department, had the vision to create the surgeon scientist training program, and this is really one of the jewels in the crown of the Department of Surgery. This is a thesis-based graduate training program, and many of our residents in the Department of Surgery take advantage of this, and this just gives you a sense of the accomplishments. Almost 500 people have achieved graduate training, many at the PhD level, and you know, we're somewhere between 40 to 50 trainees per year. And these are the students that are in our surgeon scientist training program, and these are really fantastically bright individuals, and all of the faculty are extremely proud and privileged to be working with these people. So a number of research achievements. I won't go over everything, but I just also wanted to acknowledge Andras Kapish, who is the Associate Vice Chair, and Andras is a full-time faculty researcher, and this is also to acknowledge that it's not just surgeons who are in the department, but we have full-time PhD faculty researchers. I also wanted to acknowledge Mark Jeschke, who established a translational research program. Mark will be transitioning to new roles and will be continuing on that tradition. And then we've had a number of events this past year for the Surgeon Scientist Training Program, including a career night, a meet and greet night, grant writing workshops, a town hall, PGY1 and PGY2 orientations, as well as a translational research retreat. And this is the Translational Research Committee, and this has really become a very vibrant a committee that is closely associated with various accelerator programs, sparking innovation at the University of Toronto. This just gives you a sense of the grant capture, over $100 million a year in grant capture, so that's pretty remarkable, and I think this is one of the signatures that has contributed to the recognition of the Department of Surgery at the University of Toronto as one of the top 3 in the world. Number of publications, and not just the number, but extremely high impact publications in top-tier journals, and we're also supported by a very vibrant and active advancement office. You can see over $6 million raised, and a shout out to Effie Orden representing the advancement office in the Department of Surgery. So a big thanks to Val, Andrea, also Tim Warden on my team for their assistance. Big thanks to Barbara Haas, Aaron Noth for serving as co-chairs today. And I won't obviously read all of the discussants and judges, but we really had very strong support from the faculty who I think are very invested in the success of this program. And finally, a big extra thanks to Val Cabral. And this is also a special GallieDay for Val, because Val, who started as a baby in 1975 at the University of Toronto and has been for 25 years the program coordinator for research in the Department of Surgery, will be retiring. I tried to convince her not to, but you know, that's just the way it is. And so a big shout out to Val, and we're extremely grateful and privileged to have had the chance to work with you. So on that note, I'm going to hand over to Dr. Aaron Noth, who will be chairing this morning's trainee sessions. Aaron is a very accomplished orthopedic surgeon trauma team leader at St. Michael's Hospital, University of Toronto. So Dr. Noth, over to you.
Thanks, Dr. Fales. Good morning, everyone, and I'll add my welcome. Yes, thank you. So we're going to begin the morning with the oral presentations. The first talk is going to be given by Julian Daza, who is a general surgery resident. The title of his talk is Improved Re-Estimation of Perioperative Cardiac Risk Using the Surgical APGAR Score, a Retrospective Cohort Study.
Thanks, Dr. Noth, and thanks everyone for being here. My name is Julian Daza. I'm a general surgery resident here at the University of Toronto and a PhD student through the Surgeon Scientist Training Program. And the premise of my talk is really how we estimate risk in surgical patients and how we could potentially improve this by using intraoperative information that we routinely collect anyways. And I guess the first question is, how do we currently use intraoperative information when we guide care for patients? And for this, I'm going to pose 2 very basic scenarios that I really think convey the message of my talk altogether. So the first is a patient who is seen in the preoperative clinic, in the preoperative anesthesia clinic, who is deemed to be at high risk of perioperative complications because of their comorbidity burden. This patient then goes on to have an entirely uncomplicated surgery. They tolerate it very well. And then the question becomes, what do we do with this patient postoperatively? If we turn to Canadian guidelines, for example, Canadian Cardiovascular Society guidelines, if this was a patient with a high cardiac risk profile, they would still be required to undergo troponin surveillance for at least 3 days with ECGs to look for signs of myocardial injury. So it really doesn't consider the intraoperative events. Now, Let's pretend we have the opposite now. We have a patient with a low comorbidity burden who is seen in the pre-op anesthesia clinic, and they're deemed to have a low perioperative risk of any complications. But this patient then goes on to have a very unstable surgery with lots of bleeding, and they don't tolerate it very well. If we look at the guidelines, there's actually no recommendations as to how we would treat this patient, how we would use the intraoperative information to guide care for this patient. So I guess the point that I'm trying to get across is that we don't really use this information very well at the current moment. And it's really left up to the anesthetist or the surgeon to decide what we would do with these patients, which really creates a lot of variability in how we care for these patients. In 2007, a group at Harvard University led by Atul Gawande created the surgical APGAR score, which is meant to be a risk index that's very simple to use, hence why they call it the APGAR score, the surgical APGAR score. It combines 3 intraoperative parameters: mean arterial pressure, heart rate, and blood loss, and it does so to predict what kind of outcomes patients might have after surgery. So the question that we asked ourselves is, can we evaluate the prognostic validity of the surgical APGAR score, and does it contribute any incremental value to what our current standard of care for risk assessment is? So we're looking for incremental prognostic value. So here are the comparisons that I'll be making throughout this talk. Our standard risk assessment tool we've decided is the Revised Cardiac Risk Index, the RCRI, mainly because it is universally applied for most of our surgical patients that have non-cardiac surgery. And the combined strategy is one which uses the standard tool, the RCRI, but that also combines the surgical APGAR score to sort of recalibrate those risk estimates. We conducted a retrospective cohort study from Toronto General Hospital by utilizing institutional databases that contain really rich information on preoperative characteristics, intraoperative vital signs, as well as postoperative outcomes. We restricted our cohort from 2008 to 2014. And because we were looking mainly at patients who had elective surgery who were seen in the pre-op anesthesia clinic, it meant that we excluded cardiac, transplant, as well as urgent procedures. Again, these are the 2 indices that I'll be comparing. The Revised Cardiac Risk Index is typically administered at the pre-op anesthesia clinic, and the surgical APGAR score is administered immediately after surgery. Just as a reminder, the RCRI contains 6 preoperative factors or indicators, mostly related to cardiovascular risk, such that a patient's score can range from 0 to 6, with 6 indicating higher risk. The surgical APGAR score, on the other hand, is administered right at the end of surgery. It contains 3 parameters: blood loss, lowest mean arterial pressure, and lowest heart rate. 2 of those are scored from 0 to 3. 1 of them is scored from 0 to 4, such that a patient's score can range anywhere from 0 to 10. In our cohort, we included 16,835 patient encounters. This was the distribution of surgical procedures that are included in our cohort. Most of them were in head and neck, urology, and general surgery, and the least frequent was vascular surgery. And the first question that we asked ourselves is, does this combined strategy with the surgical APGAR score and the RCRI improve the discrimination of postoperative myocardial injury compared to a strategy that only considers the RCRI? So as I alluded to just now, the criteria and outcome that we'll be using throughout to validate the surgical APGAR score is myocardial injury, and I can answer questions about that later, why we use that, but essentially it's correlated with both short and long-term outcomes, and it's also widely accepted as a core outcome measure in perioperative cardiac studies. So in our cohort, 607 patients had myocardial injury after surgery, which is approximately 3.7% of them, which is approximately what we expected. We first plotted ROC curves as a metric of discrimination for postoperative myocardial injury. We first plotted the RCRI, which is, again, the current standard of care, and we saw an area under the curve, again, as a metric of discrimination of 0.68, which really aligns with what the literature has shown us up until now. We then plotted the combined strategy, RCRI with surgical APGAR score, and we saw an area under the curve of 0.75, which alludes to a significant improvement. So now that we've established improved discrimination of the combined strategy, we then ask ourselves, can we better reclassify patients when we use this combined approach? For this, we use net reclassification statistics. So we divided our cohort into patients who had the event, which was 607 of them, and patients who did not have the event, which was myocardial injury. So if we see the numbers here, there was 607 patients who had the event. When we use the surgical APGAR score, we can correctly reclassify 53% of those patients, but it also meant that we incorrectly reclassified 47% of those patients, leading to a very small net improvement of 5.4%. So that's not very impressive. But when we look at the non-events, patients who don't go on to have myocardial injury, we were able to correctly reclassify 74% of those patients. Only 26% of those patients were incorrectly reclassified, leading to a net improvement of 48%, which is quite significant. From there, we get what's called the Net Reclassification Improvement Index, which was 54% altogether. And I can interpret that later on, if anybody needs to. The final question that we asked was, well, we've established improved discrimination, improved reclassification, but is there any clinical utility in this combined approach? And this does require a little bit of a more complex analysis, which is a decision curve analysis. This type of approach, or statistical approach, essentially quantifies the harms of a prognostic tool, the benefits of a prognostic tool penalized by the harms that the tool causes. In more statistical terms, the benefits of the tool would be the true positives of the tool, penalized by the false positives that the tool gives you. And notice here that I have multiplied the false positives by a weight. So you weigh the false positives based on the consequences of having a false positive. So for example, if the outcome is cancer, having a false positive would be weighed more heavily because of the consequences of having a false positive, meaning subsequent biopsying, subsequent testing, unnecessary anxiety for a patient. And you may be wondering, well, this is all very subjective. It's really not just depending on the outcome, but also the patient perception and the clinician perception, and that's correct, which is why we plot a range of decision thresholds or threshold probabilities, which really relate to how you weigh those false positives. So in a decision curve analysis, we can plot a strategy for a patient or what a patient would weigh a false positive if they're risk averse, as well as if they're risk tolerant. So that's why we plot a range of threshold probabilities. We start our decision curve analysis by plotting two risk assessment strategies, which ironically don't involve any risk assessment at all. One in which you intervene on all patients, as shown in gray, and one in which you intervene on no patients, as shown in black. And by intervening, I mean what kind of intervention would result from your risk assessment strategy. So if this was the perioperative setting, it would be recommending troponin surveillance on patients, depending on their risk factors. So these strategies don't really mean anything, but you'll see why they're important to plot. We then plotted the net benefit for a strategy in which we only use the RCRI, and as you can see here in blue, it leads to improved net benefit almost at all the threshold probabilities, which is good. This is our current standard of care. And when we plot the combined strategy with the RCRI and the surgical Apgar score, we actually do have net benefit gains at all threshold probabilities, indicating that there is clinical utility in this combined approach. I won't get into too many of the details of sensitivity analysis, but clearly we did make some strong assumptions about our outcome. So we repeated all of our analysis in three subsets of patients. One was a vascular surgery cohort alone, mainly because these are patients who typically receive troponin surveillance after surgery, and the estimation of myocardial injury is a little bit more accurate. We repeated all of our analysis using 30-day death as the outcome, mainly because it's related to myocardial injury, but it's less prone to detection bias. And then we made different assumptions about the relationship between the surgical Apgar score and myocardial injury by using nonlinear terms. And I won't show the results, but essentially we found robust findings of similar patterns of discrimination, reclassification, and utility across all three sensitivity analyses. So what we conclude from this is that the surgical Apgar score does in fact improve our estimation of perioperative cardiac risk when we combine it with our current approach, and that this value or prognostic value appears to be driven by improved reclassification of non-events, mainly, or in other terms, improved sensitivity. And although we've shown pretty robust findings of improved prognostic validity, we cannot recommend that it be used just yet because we don't have a clinical decision rule as to how we would apply the surgical Apgar score in practice. So that's really an area of future research. And that's it. I can take questions now.
Thanks very much, Julian. So we're going to discuss each paper for about several minutes after the presentation. So I'd open the floor to any questions. If anybody does have a question, I'd ask you to come to the mic so that those that are online can hear the question that's asked as well as the response. Maybe while people are getting a chance to come up, I'll start off. Julian, how did you calculate the blood loss? Was that something that was taken from the operative record in your study?
Yeah, so these are institutional databases, so it would be exactly what the nurses report on their chart. And it was important for us to do it like this, because if this approach were to be implemented in clinical practice, we'd want to make it as easy and automated as possible, and not making a burden for whoever is calculating it. So it's already sort of mandatory that nurses report this on their own documentation, so this is how we did it.
Okay.
Can you
I was
guys hear
wondering
me
about the
okay on the
accuracy of
Zoom?
that estimate. The other question I had was about your sort of primary outcome was myocardial injury, and you didn't get into kind of the details of what that was, what was classified as myocardial injury post-surgery.
Yeah, thanks for that question. So myocardial injury is sort of a very common outcome that's used in the perioperative literature. It's very broadly defined as a rise in troponin above the 99th percentile, and that's based on what population norms are. So that includes both, myocardial infarcts, but also elevations in troponin that aren't formally defined as a myocardial infarct. So it's been extensively validated as a prognostically relevant outcome that correlates with short-term outcomes, long-term outcomes, and that is relevant is particular in the perioperative literature because of all the sedation that patients have after surgery. It's really hard to classify myocardial infarcts or formally diagnose them as myocardial infarcts. So this is sort of a broader definition of a relevant cardiac outcome.
Dr. Swallow?
Very nicely presented, Julian, and quite clear. I'm wondering about the measure that you used as influenceable, which was the troponin monitoring. Could we generalize that to something that has even more resource implications, such as what's the setting in which they should be monitored post-operatively? Do your results have any sort of hints about that?
Yeah, so I posed the example of troponin surveillance as that strategy, that intervention you would apply afterwards. But as you mentioned correctly, and in fact, as we were going through the peer review process, this was something that really stuck. There's many more strategies. So one would be, for example, do we admit a patient to a monitored unit after surgery or not? The other one is, specific to general surgery, is early discharge after colectomy. Could this be applied, as a strategy to decide, is it safe to discharge someone from the PACU directly? So yes, there are many other strategies. I would say troponin surveillance, I constantly use it throughout because it's one of those strategies that's been most recently recommended by CCS guidelines that continues to be sort of an issue because of uptake. This could be one way of sort of, targeting more specifically who does require troponin surveillance as opposed to recommending it for all patients.
Bobby?
Yeah, Bobby Anigal from St. Mike's. So, fantastic study. We frequently see CABG patients who found to have coronary disease post lap chole, or et cetera, et cetera. So of the patients who've had a high preoperative cardiac risk, how many of those have had stress testing? And is there any correlation between those who eventually have an outcome?
So I guess that'd be a bit of a different, we didn't quite get into that, and we don't have that kind of information using these databases. I would say based on trends in perioperative guidelines, not very few of them would, mainly because the RCRI is typically administered like 3 days before surgery. So, and there's been many studies. In fact, my supervisor published one of them in 2009, I believe, which showed that stress testing doesn't really add much benefit. In fact, it probably just delays surgery unnecessarily and may potentially be associated with some harm.
Yes, second microphone.
There's rises in troponin and there's rises in troponin. So what did you consider a rise? Because you alluded to the fact that vascular patients, most of them get troponins post-operatively. And we often see, 24 is the upper limit of normal. So, is 30 enough to qualify as a positive in your study? Or did it have to be a number of times the upper limit of normal? So that's my first question. And secondly, how much did it actually predict the 30-day mortality?
Yeah, so we kept it very simple to like what we define myocardial injury. It was what the threshold is to define 99th percentile based on population norms. So this was the Abbott assay, the troponin assay that we used. So we just simply used what their population norms were. So 99th percentile, anyone above that would be classified as myocardial injury. With respect to your second question, when we used 30-day death as the outcome, the patterns of of how the surgical Apgar score behaved to prognosticate patients was exactly the same. We saw, improved discrimination almost to like the same level, but also improved reclassification in the same way, in which non-events were reclassified much better than events, which is, I think, very compelling evidence.
Okay, thank you.
Okay, that's great. Thanks, Julian.
Yep, thanks.
Okay, so our next speaker is Severa Bunda. She's an affiliate scientist in Dr. GallieDay's lab. And the title of her talk is YY1 is a novel CIC co-repressor.
Thank you. Hello, everyone. Thank you for allowing me to speak today and to present our work. The title of my talk is YYY is a novel CA co-repressor in glioblastoma. So what is YY1? Essentially, what is CAC first, and why do we care to study it at all? CAC, or Capicua, has recently emerged as a negative regulator of receptor tyrosine kinase responsive genes. In particular, what it does, it sits on the promoter of these genes, sits on specific octameric motifs, and actually does not allow transcription of the genes to occur. Once signaling is initiated, ERK enters the nucleus, as you can see here, and actually alleviates the transcriptional repressor from the promoter, allowing transcription to occur. This is interesting because, as you know, a lot of you know, the receptor tyrosine kinase signaling, and especially the RAS pathway, is highly hyperactivated in most tumors. So one would imagine then, actually what I want to say, that the best studied genes downstream of ERK that are known to be repressed by CAC are oncogenic transcription factors ETV1, 4, and 5. It is not surprising then that CAC mutations have been shown to occur in various tumors. The most frequent alterations in CAC occur in a subset of oligodendrogliomas. In glioblastoma, the tumor that we are most interested to study in the lab, which is the most aggressive primary brain tumor in adults, we know that CAC is not mutated. However, we know that the receptor tyrosine kinase signaling is hyperactive in most of the patients, in up to 90% of the patients. So we simply ask the question, what is happening to the CAC protein in glioblastoma? So to do this, we initially just obtained a bunch of primary patient-derived tumors, and we profiled the protein expression. And for the most part, in about 30 tumors that we profiled, we found that CAC protein is actually absent. Despite intact mRNA levels, CAC protein was no longer there. This was suggested to us that there's post-transcriptional mechanisms that are operating to ensure that the protein is no longer there, the repressor is not active, allowing the expression of these genes to occur. Subsequently, we found that there's two parallel mechanisms that are operating to do this. One is ERK-dependent. ERK enters the nucleus, and in this way alleviates the repression of CAC from the genes, leading to its degradation in the nucleus. Subsequently, there's a parallel mechanism that ensures that any CAC that is unbound to the DNA is quickly exported outside to the cytoplasm, and this is regulated by the non-receptor tyrosine kinase ERK. So one would imagine then simply what do? We should just be able to inhibit this signaling pathway, restore CAC protein, and sensitize these cells to these inhibitors. Unfortunately, we did not see that. Short-term ERK inhibition did do this. We used primary patient-derived glioma stem cells, and we show that if we do short-term up to 6 to 12 hours of inhibition with selumetinib, which is a MEK inhibitor, we are able to restore CAC protein levels. However, sustained and long-term inhibition with selumetinib, both in vitro as well as in vivo, did not restore CAC protein levels. This is actually interesting now to give us some. You can imagine that even though we're inhibiting the upstream pathway, if the repressor is not there, the genes are still going to be expressed. So it actually emerged in other cancers, in other contexts, that CAC inactivation, the protein loss or other mechanism, is actually required resistant mechanisms to these inhibitors. What we found in the lab, that if we actually introduce a CAC degradation-resistant mutant, so we actually engineer a mutant that binds to the DNA independent of the upstream signaling, we're able to resensitize these cells, both in vitro and in vivo, to a MEK inhibition. However, since we can't introduce this to the patients, we wanted to actually get a little bit more insight in how can we actually regulate CHC repressor function in order to be able to restore these the effect of these inhibitors. Actually, very little information, mechanistic information is known about CAC. Most studies have been done in Drosophila. We do know that CAC and protein and repressors like CAC typically never work alone. They always work with co-repressors to regulate transcription of genes. We do know that a taxin binds to the DNA binding domain of CAC, but this is important for CAC stability, not so much as a typical co-repressor. So to study this, we conducted an exploratory mass spectrometry. Essentially, as you can see, there's a schematic over here. We utilize the octameric motif in which ETV binds to. We biotinylate it. We pulled it down with streptavidin beans, and we conducted a mass spectrometry. In addition to a taxin, CAC, and other known CAC binding partners, we were able to pull down YY1. And this was interesting because YY1 is a transcription factor that is important in tumorigenesis, but it's also context dependent. It can be an activator or a repressor, depending on the cellular context and the proteins it binds to. Recently, actually, just this year, it's been shown that YY1 is also important in GBM. So the first thing we wanted to do is obviously validate these findings in vitro, and as you can see here, we're able to pull down endogenous YY1 on the ETV5 oligo. Mutant scrambled DNA does not do this, gives us some confidence. We conducted a chip assay as well, showing that there is definitely binding between the two. In addition to that, we wanted to be more specific to our cell type, the tumor that we're studying, so we obtained both GBM cell lines and primary patient-derived glioma stem cells. We reintroduced CAC into these cells because we know that these cells do not express it because of this mechanism that's operating. And again, you can see nicely that we're able to pull down not only CAC, which is known, but also YY1. Endogenous YY1 strongly comes in only in the cells that express the CAC. So now that we know that there's binding that's occurring on the DNA between the two proteins, I didn't show you that, but we wanted to get what is the functional consequence of this binding? Is there a functional consequence? So to do this, we actually created CAC truncation mutants. What I want to state first that it's important to know that CAC has three very important functional domains. There's the DNA binding domain, there's a C2-ERK interface domain, and there's a C1 repressor domain, which is found all the way at the end of the protein. It was recently found that the DNA binding domain alone is not able to cause repression of the genes. Essentially what happens is that the back and the front need to work together to actually cause the repression. You can see this here from the publication and schematic. Interestingly enough, when we do co-IP assays using these mutants, the only construct that robustly was able to pull down CAC was the one that had the intact C1 repressor domain. This gave us some confidence, some insight that very likely the binding between CAC and YY1 is required for repression. So to study this further, we deleted YY1 using CRISPR technology. As you can see, and then asked the same question, what happens now to the binding in CAC in the absence of YY1 to the DNA oligo? As you can see, it's completely lost. We conducted chip analysis to confirm this, and very nicely you can see at the bottom, if the repressor is no longer binding to the genes, what happens? We have upregulation of these factors, ETV1, 4, and 5, expression goes up. And not only in HEC293 cells, which is our go-to molecular kind of biology system, but also in the more relevant normal human astrocytes, the same occurs. So deletion of YY1 actually leads to de-repression of these genes. Again, we were interested to see what happens in the GBM cell lines and the glioma, patient-derived glioma stem cells, so we did very similar assays. And as you can see, in both the cell line and the GSC line, we were able to, when we knock down YY1, a reintroduction of CAC, the loss between CAC and the DNA is significantly impeded in both situations. This then goes on to, so again, one can imagine when the repressor is no longer binding to the gene, what happens? There's significant upregulation of ETV1, 4, and 5, despite having intact CAC protein. So now we can say that up to this point, we know that YYY binds to the close to the C1 repressor. It helps CAC cause the repression of the genes. What we wanted to know next now, what are the cues that actually lead to, what are the cues upstream of receptor tyrosine kinase signaling that actually mediate this event? So if we go to the publication, in 2011, there was a nice molecular study done on CAC, and that actually showed that downstream of ERK, P90 risk is responsible for mediating the binding of CAC to the DNA and mediating its repressor function. This gave us some, this is right downstream of ERK, so this gave us some insight as to possibly could P90 risk be mediating this. So before I show you the data here, I think it's important to show that P90 risk definitely is active in all of our primary patient-derived glioma stem cells. It's also highly active in all of our tumors, primary patient-derived tumors. So what happens now? If we actually inactivate this using a well-known P90 risk inhibitor, are we able to inhibit the signaling and restore the interaction between the two? So first, we show this using glioma stem cells, and again, once again, very nicely, when we inhibit P90 risk, we're able to enrich not only CAC but also YYY onto the DNA. What's most important is that we can see that in these primary patient glioma stem cells that don't have very low CAC expression, just using P90 risk alone, we're able to restore the protein level. You can now imagine if restoration of the protein level should then lead to a decrease of expression of these factors. And indeed, that's what we see. To tie back into where we started, as I showed you, long-term inhibition with MEK inhibitors did not restore CAC protein levels. And interestingly enough, we wanted to probe to see what's happening with P90 risk there. Despite having an active ERK, and you can imagine if you inhibit this, this should be inhibited. However, with long-term, there's other mechanisms of reactivation, and we see robust activation of P90 risk. So this gave us now some insight and some functional understanding of why perhaps we're not seeing no longer CAC protein, because we have reactivation of this, then leads to the subsequent degradation. So what happens now, we would imagine that if we do a double inhibition, if we inhibit P90 risk and ERK, should we be able to restore some sensitivity to these inhibitors? And indeed, we can see using primary patient glioma stem cells, just when we combine both selumetinib, the ERK inhibitor, and BID 1870, the P90 risk inhibitor, we're nicely able to resensitize these cells to the proliferation of these cells is significantly affected rather than using either inhibitor alone. And this is also nicely seen using neurosphere assays. So just to conclude and summarize, I've showed you that there's an interaction between CAC and YY1. This interaction of YY1 is important for CAC's repressor function, so we can call it a co-repressor. This interaction is mediated by P90 risk, which is downstream of ERK. I've also showed you that P90 risk is reactivated once we treat these cells with long-term selumetinib treatment. So now, if we inhibit this arm of signaling, with this arm, we're able to resensitize these cells to ERK inhibition, which is a problem in many tumors. So I'd just like to acknowledge Dr. Galleri-Zada and everybody in her lab, Dr. Aldape and Dr. Richard Young at MIT. Thank you.
Thanks very much, Severa. Very nice presentation. Once again, we'll open up this paper for discussion, so any questions, please come to the mic. And if there's any online discussions as well, please make yourself known and we'll get you in the queue to ask a question. Hopefully some of the neurosurgeons come to the mic because I'm not really smart enough to ask you any questions about your paper. I do remember from my neurosurgery rotation, and
everybody.
Gallery was my senior resident on my neurosurgery rotation, that GBMs are bad. So maybe you could speak to the clinical translation of your work and where this is going to get us in terms of treating GBMs.
So hopefully the idea is that because we know that not only in GBM, these tumors are really, these inhibitors, the RAS-ERK inhibitors, they're heavily studied. Unfortunately, there's always acquired resistance mechanisms. I'm showing here one of those. It's interesting enough that you would think that if you inhibit something upstream, its downstream target should actually be obviously inhibited as well. We don't see this. We see reactivation of it very likely through P38 MAP kinase. It reactivates it. Again, cancer cell finds another way to actually get rid of this protein, despite, so I think that the clinical significance is to combine these two. If we understand molecularly more what's going on, we'll be able to clinically apply these things. So if we apply the P90 risk inhibitor with the MEK inhibitor, which is kind of counterintuitive because one should inhibit the other, but it doesn't. So if it will be able to resensitize, I guess, the cells towards ERK inhibitors that are actually failing in the clinic.
Dr. Rucka?
Yeah, Severa, fantastic, really elegant work. The biochemistry and molecular biology is extraordinary. Most of your work was in vitro based, right? And a carryover from Aaron's question was, can you take this into some kind of preclinical model in vivo and demonstrate the same thing and also have some kind of drug approach to this that you can measure?
Yeah, this is the next step, right? We're looking to do this in mice using intracranial xenografts. We did it with selumetinib alone and we failed, so now we're doing co-treatments with the two inhibitors and hopefully hoping that what we see in vitro can translate in vivo. And if it doesn't, then we'll do RNA-seq studies from that to see what else is happening. But I think that take home, I'm sorry if it was too molecular, too confusing. The take home is that this repressor that is important for the signaling, if you inhibit upstream pathway, the repressor is not there, it doesn't matter. The genes will still be, those genes, the oncogenic genes are still there. So we need to focus on trying to restabilize this in the cell.
Great. I think we have an online discussant with a question. Can we maybe cue that up?
Can you hear me?
Yes.
Thank you. I just want to congratulate you on a beautiful study. Yes, it's complicated and it's very difficult. So not only is it relevant, as the moderator mentioned, to neurosurgery, but it's really an important study for us to understand context and the signaling pathway for other human cancers. And as many of you know, in the sarcoma program, we call it CHIC, actually, not CIC. We have CHIC-DUC oncofusions, which are activating, not repressors. So maybe I'll just end this active discussion on your very fantastic work to ask you, what do you think the next steps are? In some ways, maybe I'm not that confused that it's different. What you expected to be able to use for combination therapy is different. Obviously, drugging these downstream RAS, ERK pathways is incredibly complex. So what do you sort of see as the future next steps to try to get your work into human brain tumors and maybe in different contexts, human sarcomas? Thanks again.
Thank you for being so generous. I think initially, in vivo. We have to start in vivo and see if we can actually recapitulate this in our mouse models using not only one patient-derived cell line, but multiple, because we know that GBM is very heterogeneous. The take-home really was that all of the lines that we had, the primary patient tumors and the lines, that all showed hyperactive ERK, they all show P90 risk. So if we can recapitulate this in vivo, I think because both of these inhibitors are already used in the clinic, and if we do have good enough data, then the next step would be to take it preclinically. I think, but in vivo, I think that's a first step.
Great, fantastic. Very nice work.
Thank you.
Okay, the next speaker is Moath Sagaf. His supervisor is Dr. Anastakis. He's a plastic surgery resident from our surgical scientist training program. And the title of his talk is The Effect of Early Active Range of Motion Following Tendon Transfers on Complications and Health Status, a Propensity Score Analysis and Economic Evaluation.
Yeah, thank you so much for the introduction and for allowing me to present today. We would like to disclose that this study is funded by the American Foundation for Surgery of the Hand. Tendon transfers are procedures that are commonly done to move one functioning musculotendinous unit to another location, most commonly to restore function. They're commonly indicating following traumatic tendon injury or a nerve injury. There are two major post-operative rehabilitation protocols. The majority of surgeons would immobilize patients following tendon transfer for 3 to 4 weeks after surgery, and would only start rehabilitation afterwards. A smaller proportion of surgeons would start mobilization early, within a week following surgery. The standard of care currently remains to be immobilization. Our literature on tendon transfer is a bit lacking. We know from tendon repair literature that there are many advantages of mobilizing the tendon early. There is lower risk of adhesions, and there is also pain improvement. However, the main concern with tendon transfer is the risk of rupture or tendon pullout. And there is also a theoretical risk of increased visits with rehabilitation when you start it early. This is a critical gap in our literature. And to address it, in this body of research, we had 3 aims. We wanted to compare the rates of postoperative complications between the early active range of motion protocols and delayed mobilization. And we also aimed to assess the impact of early active range of motion and health status. And finally, we wanted to factor all these elements in an economic evaluation to affect and study the cost utility of these approaches. For the first aim, we designed a retrospective cohort study. We enrolled adults who had the tendon transfer surgery, and we excluded patients with conditions that would impact their participation in a rehabilitation program. We divided the study population based on the day they started early active range of motion into 2 groups. The early active range of motion group started within 7 days following surgery, and the delayed mobilization started therapy after 7 days. This data-driven approach was done to maximize statistical efficiency. Our primary outcome was a time-to-event outcome to the composite postoperative complication that encompasses tendon rupture, tendon adhesions, and readjustment of tendon tension. In our statistical analysis, we derived propensity scores based on baseline characteristics along some of the surgical variables. We calculated the ATT weights and modeled that in the Cox proportional hazard model with time interaction due to violation of the proportional hazard assumption. We also investigated the effect of reclassifying our exposure and groups based on regression discontinuity analysis. And we also determined that we would require 65 participants per group in order to detect a median effect size. These are the baseline characteristics of the study participants. We had a total 141 patients enrolled in our study. And I would like to note the standardized mean difference was 0.1 or low, indicating that we achieved balance after applying the propensity score weights. Interestingly, the hazard ratio for patients who had early active range of motion was almost at the null value of 1.01 with a very tight confidence interval from 1 to 1.02. More interestingly is that the hazard rate of tendon rupture for the early active range of motion was lower, 0.38, compared to delayed mobilization, which goes against the clinical concern of tendon rupture. And in the regression discontinuity analysis, we did not find a single cutoff value that would change our interpretation of our results. So we concluded that early active range of motion was not largely associated with increased rates of major postoperative complications. Given this finding, it is eminent to know how would it impact patient-reported outcomes, specifically health status, and that constitutes our second aim. Using the same study design, we conditioned our population to those who completed the disability assessment and the health status assessment using the DASH and SF36, both of which have excellent measurement properties. We built a generalized estimative equation model for each outcome to drive the estimates at the population level with an independent correlation structure and a robust standard error estimator. We adjusted for non-confounders and of area of imbalance between our source population and our study population. These are the baseline characteristics. And I would like to note that we had 49 participants in this second aim, constituting 35% of our source population. And the standardized mean difference indicated that those patients were younger males who had more commonly nerve injuries than tendon injuries. However, their other baseline characteristics were very similar. Patients were followed from 6 months to 4 years on average, and their disability actually was improved in the early active range of motion group by 4.5 points. However, that did not reach statistical significance. More interestingly, health status, specifically the bodily pain domain, improved with early therapy by 15.3 points, which is 3 times more than the minimal clinically important difference for pain. and that was found to be statistically significant. So we concluded that early active range of motion was associated with an improvement in the bodily pain domain at long term compared to delayed mobilization. Given that there is no increased rate of postoperative complications, and there is also an improvement in the long-term pain with early active range of motion, and also uncertainties around costs and utilities, we aim to have an economic evaluation that would factor in all of these elements. So we designed an individual level simulation using Markov model from a healthcare perspective, comparing the two rehabilitation strategies over a lifetime horizon and a discount rate of 1.5%. This is the structure of our model. Our patients would enter the model with each strategy following surgery. They could have complications, and they could also require reoperations and go back into rehabilitation. And because death is the absorbing state, it was modeled as over a lifetime horizon. We modeled 10,000 patients over 1,000 outer loop sample iterations to vary the cost and utility to account for additional uncertainties. We demonstrated face validity by carefully reviewing the model structure and also discussing it with content experts. And we also had internal validation by comparing the model estimates to our own data from the previous two aims. We had some key assumptions in our model. We assumed that the operation could be attempted only twice, and that is a fair assumption. Typically, you would choose another different method for reconstruction if it's felt twice. And we also had a very conservative assumption that early active range of motion would require more rehabilitation visits. In a recent systematic review, it was found actually it's the opposite. It would require less number of visits, but we wanted to account for additional uncertainty and to be very conservative in our model. These are the model estimates. We found that early active range of motion had additional costs by approximately $2,700, and the incremental increase in the quality adjusted life years was 0.36, leading to an incremental cost effectiveness ratio of 7,600 per QALY. The acceptability threshold was around $7,500 per QALY, and that is actually way below the willingness to pay a threshold of $50,000 per QALY. So it was found to be very cost effective. And this is the outer loop iterations for the probabilistic sensitivity analysis to account for additional dimension of uncertainty. So each iteration is presented by a dot, and each green dot indicates the model was found to be cost effective for early active range of motion. And given this high uncertainty, more than 60% of the iterations, the model was found to be cost effective with a large amount of uncertainty. So we concluded that early active range of motion following tendon transfer is cost effective. We had some limitations in this body of research. We had low power to detect large differences in our first aim, and we also had some missing data in our second aim, assumed to be missing at random. And there is also an issue with measuring compliance in our study, and we had some distributional assumptions about the economic evaluation. In conclusion, this body of research tips the scales in favor of early active range of motion following tendon transfer. It had similar rates of major postoperative complications, it improved long-term pain, and it was found to be cost-effective. In the future, we plan to externally validate our data from other institutions and also to start the knowledge translation process within our hand surgeon groups and hand therapists. Thank you so much for listening, and I would like to acknowledge our divisional leadership, the research team, and my PhD thesis committee, and I would be happy to take any questions.
Great. Thanks very much, Mohad. Great presentation. I wonder, you presented some of the data on the rate of tendon rupture, and I noticed the confidence intervals were pretty wide there, and I guess there wasn't a statistical significance when you compared the two groups. Do you think that this is something that needs to be evaluated, more robustly in a prospective fashion, maybe with a randomized trial? And if so, what do you think the design of that study would look like and what the numbers would look like?
Yeah, thank you so much. That's an excellent point. I love that you brought that up. So the reason why the confidence level was very wide is because of the low number of events. So out of 141 patients, we only had incident of 4 ruptures for the whole study group. And if you were to design a clinical trial for that purpose, it would be extremely expensive because you would require a huge volume of patients, probably around 1,000 for each group, in order to detect a small effect size. And for that reason, causal methods with propensity scores from databases, if it were to capture the rehabilitation protocol, would be extremely feasible if we collect all the potential confounders. And that would be my approach. And yeah, the trend is towards that there is actually lower hazards with early active range of motion, but we would require probably a database to study that effect more robustly.
What about if you were to power something, based on, you used DASH as one of your outcome scores, so what if you were to, power it based on functional outcomes? Do you see any value in a prospective study that was powered in that fashion?
Yes, for sure. To study disability, because it's going to be a continuous outcome, that would be extremely feasible to assess that disability. If we were to assess tendon ruptures as a binary outcome, then we would require a huge sample size. And I think we had some clinical trials that are done for specific type of tendon transfers, and it was found to be, disability was a bit similar, so I would not expect it to be changed a bit. And that's also what was consistent with our findings.
Great. Kristen?
Hi, Moa. Thank you very much for your talk, and I think it's always so important that we challenge dogma in terms of how we care for these patients. So I have a couple of questions, and my first question relates to how you chose your cutoff for your two groups of early active versus not. So, first of all, is there a standard definition that you found in your literature of what is early active? And as you mentioned, I tend to kind of dichotomize it into kind of that within the first week and then over 3 weeks. But did you chose kind of you looked at the distribution of the start of early active, and did you have any patients in that who started early active in that 1 week to 3 week window? And how do you think your selection of that cutoff may have influenced your results?
Yeah, thank you so much. That's a great question. So yeah, as you alluded to, our approach was data-driven, causing the median value because we were interested to detect like a very small effect size within our own data. But in our sensitivity analysis, we varied that cutoff value within a 1 week and then after 3 weeks, which is commonly what is quoted in the literature. And our finding was a bit consistent, but the confidence levels were a bit wider. So our approach through all of these variation in the cutoff values and the redefinitions of the exposure, our interpretation did not change.
Okay. And then my second question relates to, obviously, at least personally, I know children is a little bit different than adults, but I choose my patients very carefully for an early active range of motion protocol. And I know you dealt with kind of some of the confounding by restriction and by propensity scores, but what were some unmeasured variables that you weren't able to capture in your propensity scores that you think may be really important to looking at comparing the outcomes of these two groups?
Yeah, thank you so much. So some of the unmeasured variables would be related to geography and also travel times. So for example, patients who are living close to Toronto Western, they would be easily able to participate in a robust rehabilitation program that would require them to be visited, like, for example, daily. However, patients who are living or coming in, traveling from a distance, which would be a case for sick kids, that would be definitely a limitation. So that was one of the variables we were unable to measure. And also some of the milder psychiatric issues, such as like mild anxiety, could impact these factors. And some of patients, they may not have a label for their diagnosis, and the surgeons would know that the patient was really anxious with, for example, removing the dressing changes. These variables were not, unfortunately, captured in our retrospective design, and those are unmeasured confounders.
I agree. And then what else do you think that, over time, because you included a big chunk of time period, a larger time period to look at these patients and to harvest, which you had to do, obviously, to get the volume, but rehab protocols have changed in our understanding of kind of tendon biomechanics and the appropriate positioning to avoid tendon rupture and decrease the load on these tendons. So do you think that that also may have played, like the historical bias? I'm sure a lot of the early active tendon transfers were from a more recent time period.
Yes, that is definitely another issue for like unmeasured confounder that we did not account for in our data sets.
Okay. Thank you so much, Moa.
Yeah, thank you.
That's great. Thanks very much, Moha.
Thank you.
Okay, our next speaker is Ben Lee. He's a second-year vascular surgery resident, and the title of his talk is Thresholds for Abdominal Aortic Aneurysm Repair in Canada and the United States. Ben?
Thanks, Dr. Noth, and thank you to the research committee for the opportunity to present our work today. Abdominal aortic aneurysm, or AAA, is a dilation of the abdominal aorta to greater than or equal to 3 centimeters. Intervention for this condition is indicated once AAA exceeds 5.5 centimeters for men or 5 centimeters for women. And this is defined by major societies, including the Society for Vascular Surgery and the European Society for Vascular Surgery. The reason for these thresholds is because clinical trials have demonstrated no benefit from intervention compared to surveillance below these thresholds, due to the relatively low risk of rupture compared to the surgical risks. Despite these standardized guidelines, previous studies have demonstrated significant geographic variations in AAA management. For example, throughout the US, Europe, and Australia, the proportion of AAA repaired below these recommended thresholds ranges from 6.4% to 29%. And because practice variations have an important impact on patient outcomes and resource use, it is critical to identify areas of poor adherence. To date, a direct comparison of AAA management between Canada and the US has not been performed. The goal of our study was to assess variations in patient selection, operative technique, and outcomes for elective AAA management between Canada and the US. Our data source was the Vascular Quality Initiative, or the VQI database, which prospectively captures data on vascular surgery patients across 796 centers in Canada and the US. Participating academic and community physicians regularly submit data on consecutive eligible patients, and annual audits are performed to compare registry data with hospital claims to ensure the reliability of the submitted information. We conducted a retrospective cohort study using the VQI database and included all patients who underwent elective endovascular or open AAA repair between 2010 to 2019. We excluded patients with ruptured or symptomatic AAA, isolated iliac artery aneurysms, or no recorded AAA diameter. Thanks.
Guys, we're just having a little trouble with the clicker to advance the slides. I wonder if the battery in it's dying or something like that.
Sorry about that.
Yep. Would you be able to troubleshoot it for us? Or can you advance Ben's slides for him?
So our independent variable was the region of treatment, Canada versus the US. Our primary outcome was the percentage of AAA repaired below recommended diameter thresholds. So for men, less than 5.5 centimeters, and for women, less than 5 centimeters. And our secondary outcomes were in-hospital and 1-year all-cause mortality. For our statistical analysis, the AAA diameter at the time of repair was compared between Canada and the US using probability density functions. And multivariate logistic regression and Cox proportional hazard analysis were performed to assess the relationship between region of treatment and outcomes, and we controlled for differences in baseline demographic and clinical characteristics. And here are results. In terms of our patient cohort, we included 1,400 patients from Canada and 51,000 patients from the US. In Canada, 68% of repairs were performed endovascular versus 31% done open. In comparison, in the US, 83% were done endovascular versus 16% done open. So in the US, a greater proportion of AAA repairs were performed endovascularly. In terms of our patient demographics, the mean age in Canada was 73 versus 72 in the US, with no significant difference. US patients were more likely to be female, white, be of Hispanic ethnicity, and be non-insured. In terms of the clinical characteristics, US patients were more likely to have hypertension, coronary artery disease, chronic kidney disease, and also have had prior vascular interventions. So as a whole, US patients were slightly more comorbid. Anatomically, Canadian patients were more likely to have a unilateral concomitant iliac artery aneurysm, whereas US patients were more likely to have this pathology bilaterally. And this is our primary outcome and our probability density function. So on the x-axis is the diameter of AAA at the time of repair. The vertical dotted line is the recommended threshold for men of 5.5 centimeters. So everything to the left of that vertical line means that the repair was performed below the recommended threshold. On the y-axis is the probability of a patient receiving repair. And the blue line represents US patients, whereas the red line represents Canadian patients. So as you can see, to the left of that vertical line, the area under the curve for the blue line is greater than for the red line, suggesting that US patients were more likely to receive repair below recommended thresholds. This is a similar figure for women. The recommended threshold has now changed to 5 centimeters. And again, you can see to the left of that vertical line, the area under the curve for the blue line is greater than for the red line, again suggesting that US patients were more likely to receive repair below recommended thresholds. So for our primary outcome, there was a significantly greater proportion of AAA repaired below recommended thresholds in the US at 38.8% versus 15.2% in Canada. The odds ratio for this was 3.57, and this persisted even after adjusting for differences in baseline demographic and clinical characteristics with an adjusted odds ratio of 3.57. Interestingly, during the same time period, we found no difference in the ruptured AAA repair rate between US and Canada, suggesting that repairing these smaller aneurysms did not lead to a reduction in rupture rates. This table looks at our in-hospital outcomes. The mortality in Canada was 0.8% versus 1% in the US, and this was not significantly different. Canadian patients were more likely to have a myocardial infarction at 6.6% versus 1.3% in the US. And because this did not lead to an increase in mortality, we hypothesized that this is due to asymptomatic myocardial infarctions being captured in Canada more frequently due to routine post-op troponin draws. And this may happen more frequently in Canada as this post-op protocol was developed by our colleagues at McMaster. In terms of other in-hospital outcomes, stroke, congestive heart failure exacerbation, respiratory complication, renal failure, lower extremity and bowel ischemia, there were no differences between groups. This figure looks at our one-year outcome of death and compares Canada and the US. The Canadian line is in red and the US line is in blue. And at 1 year after AAA repair, there was no difference in mortality between groups. We stratified this by endovascular repair, and again, you can see that there was no statistically significant difference in 1 year mortality between groups. And for open repair, there was no statistically significant difference between groups with a p-value of 0.2. Here we looked at predictors of AAA repair below recommended diameter thresholds. And the most important factor was receiving a AAA repair in the US with an adjusted odds ratio of 3.57. Other important factors were male gender, endovascular repair, age, and procedure year. Because endovascular repair was a major modifiable risk factor, we looked at anatomic characteristics and patient selection for patients undergoing endovascular repair between Canada and the US. In terms of anatomic characteristics, when we decide whether a patient is suitable for endovascular repair, the most important factor is their aortic neck, which is the region of the infrarenal abdominal aorta that is healthy before it becomes aneurysmal. And this helps us determine whether the patient can get a good proximal seal on the endograft. So for the aortic, sorry about that. So for the aortic neck length, generally we want this to be at least greater than 10 millimeters. And the proportion of patients who did not meet this criteria in Canada was 2.1% versus 1.7% in the US, and this was not statistically significantly different. The aortic neck diameter, generally we want this to be less than 32 millimeters, and the proportion of patients who did not meet this criteria in Canada was 0.4% versus 1.2% in the US, and this was significantly different. So a greater proportion of US patients were receiving endovascular repair, even though their aortic neck diameter was not meeting criteria. In terms of patient selection, interestingly, we saw that in Canada, 62% of patients who underwent endovascular repair were deemed by their surgeon to be unfit for open repair. either due to cardiac or pulmonary comorbidities, frailty, or a hostile abdomen, whereas this percentage was 14% in the US. So the vast majority of US patients who are undergoing endovascular repair were suitable for both open or endovascular repair, but the surgeon and the patient decided to go with endovascular repair. So it was interesting for us to see this stark difference in surgical decision-making between the two countries. In conclusion, we found significant variations in AAA management between Canada and the US, despite standardized guidelines. US patients in particular are more likely to receive AAA repair below recommended thresholds at 38% versus 15%. And this is partly driven by a higher rate of endovascular repair in the US. Despite these differences, outcomes remain similar between the two countries. Future studies should assess the reasons for these differences, and AAA care should be standardized based on guideline recommendations. Thank you very much for your time.
Very nice presentation, Ben. Once again, we'll open up this paper for discussion. If there's anybody on the online discussants, please let me know. Yeah.
Hi, Ben. Chris Forrest, plastic surgery. That was a really elegant presentation. I know very little about this type of thing. I did a rotational vascular surgery many years ago. But I'm interested to know what the natural history is of these smaller aneurysms. And also, maybe the reason for endovascular repair in the US is cost-driven. And did you do a cost analysis between the open and the endovascular repair? But very, very good presentation. Thank you.
Thanks, Dr. Forrest, for that question. So in terms of the natural history of small aneurysms, there were clinical trials that were performed early in the 1990s, and they randomized patients with small aneurysms, so they defined that as less than 5.5 centimeters in men, and they randomized them to either surveillance or repair, and they found no difference in outcomes for the two groups. So in terms of the natural history, these small aneurysms, they have a relatively low risk of rupture compared to the surgical risks, which is why the major bodies suggest not repairing these smaller aneurysms. In terms of the cost effectiveness analysis, I think that would be a great avenue for future study. I think performing interventions that are unnecessary for patients, number one, exposes them to harms, and also given the financial burden on our current healthcare system, increases costs and also takes away opportunities for other patients who require surgery more urgently. So I think doing a cost analysis would be a great avenue for future study.
Thank you.
Maybe I'll go to the second microphone.
Great. Tom Forbes from UHN. Ben, great presentation. We've heard it a number of times. I'm going to challenge you a little bit, though. You framed it as an international comparison between Canada and the United States, but these procedures are limited to those that are included in the VQI, right? And we know that only about 35% of American surgeons upwrote their patients into VQI, and probably a smaller percentage of Canadian surgeons. So how representative of this of national experience, and could you use other databases to get maybe a more representative sample?
Thanks, Dr. Forbes. One of the limitations of this registry is centers voluntarily participate in providing data. And so you're right, only about 35% of data is probably captured. I think one of the strengths of this database is it captures both Canadian and US data, specifically for vascular surgery patients. And there isn't another database out there that would allow us to compare these two countries directly. So I think there are kind of strengths and limitations to this database, I think the data should be interpreted with those in mind. Thank you for that point.
Great. Can we? I think we have an online question. Can we go to that one? Is Charles online? Hey, Charles.
Hi, thank you, Ben, for that excellent presentation. I was wondering about the center representatives in this as well, but I was wondering if you had done a stratified analysis based on repair approach for the threshold of repair.
Got a little bit of feedback there, Charles. Can you just repeat the question?
Sure. I was wondering about the threshold of repair analysis between endovascular and open repair. You presented the outcomes.
Oh, I see. we didn't stratify by endovascular versus open for looking at the diameter threshold. We did stratify by men versus women because the thresholds were different. But we actually controlled for repair type in that analysis. So that was kind of how we adjusted for that as a confounder in terms of endovascular versus open. We adjusted for that in our multivariate model.
Okay, thank you.
Great. Thanks very much, Ben. Nice presentation.
Thanks, Dr. Nath.
Okay, our next speaker is Nardine Samuel, who is a PGY4 resident in neurosurgery, part of the surgeon scientist training program, and her talk is the investigation of focused ultrasound-induced neuroplasticity of the human motor cortex using transcranial magnetic stimulation and magnetoencephalography.
Thank you. Let's see if this works. Okay, thank you very much, and thank you to the organizers of GallieDay for giving us the opportunity to present our work.
I think it was working best when he was holding it off to the side a bit.
Okay, so the term neuromodulation, broadly speaking, as it refers to the brain, because there are tools for neuromodulation of the spinal cord and peripheral nerves, it refers to transient alterations in neural circuits for the purposes of treating diseases of the brain, such as neurologic disorders and psychiatric diseases. This can be done in an invasive fashion, so using surgically implanted devices like deep brain stimulators, which is a modality that's used, for example, to treat Parkinson's disease and other movement disorders. There are also non-invasive approaches to stimulating the brain that involve utilizing different types of energy that's transmitted through the skull. This includes magnetic, ultrasonic, and electrical approaches. And these tools that we have at our disposal, they vary along the continuum of cost, with the more invasive approaches typically being more costly. But these approaches, which require surgery, are also typically more efficacious and have very high spatial resolution because they're targeting very specific areas of the brain. This comes at the cost of potential complications, so perioperative risks or postoperative infectious risks, as well as hardware failure and risks of having a foreign body implanted. And so the gap that exists is really there's a lack of effective and accessible forms of non-invasive neuromodulation in order to treat diseases of the brain. And this is where low-intensity focused ultrasound comes in. I just want to mention this is distinct from high-intensity focused ultrasound, which is what you're going to hear about in the next talk. But low-intensity focused ultrasound, or LIFU, is really a state-of-the-art tool for non-invasive brain stimulation. And how it works is it utilizes ultrasound waves with frequencies above the range of human hearing, so typically above 20 kilohertz. And an ultrasound beam delivers acoustic energy into the brain through with very high spatial resolution and very precise regions. This energy is actually delivered at non-ablative intensities, again, distinct from high-intensity focused ultrasound. And the language of the brain, the language that the brain speaks is electricity. So neural conduction occurs through electrical impulses, but the brain is also a mechanosensitive organ, and this is how focused ultrasound works. So it targets mechanosensitive ion channels, or how it's thought to work. It's thought to target mechanosensitive ion channels, and also alters the lipid bilayers of presynaptic and postsynaptic membranes to alter neural conduction. So this tool was actually first identified almost 100 years ago as a mechanism for stimulating excitable tissues, but it really wasn't until over the past decade or so where several studies have come out demonstrating the impact of low-intensity focused ultrasound at the cellular level in animal models, as well as its ability to target superficial as well as deep brain structures. And in fact, it can do so with very high spatial resolution. And so this is an ultrasound field potential here that you can see is on the order of millimeters. And this capitulates the type of spatial resolution that you get, for example, with a deep brain stimulator with an electromagnetic field that's generated also on the order of millimeters. And you don't get this type of spatial resolution with some of the existing forms of non-invasive brain stimulation, such as transcranial magnetic stimulation or transcranial direct current stimulation. And so this is very exciting, and there have been various studies actually only over the past year or so that have demonstrated that this is safe to use in humans. But in order for us to actually translate this clinically, we need to better understand how is this actually affecting the brain. And to do this, we designed a randomized, sham-controlled crossover study looking at the neurophysiologic response of transcranial focused ultrasound to the motor cortex in healthy individuals. We utilized a specific protocol known as a theta burst protocol, which was recently published by Dr. Robert Chen's group. And we recruited subjects and randomized them to receive either sham or active ultrasound in separate visits, separated by at least a week or more. And then we brought them in for a third visit to perform an anatomical MRI, which would then subsequently we would use for our analysis. And at each visit, we performed measurements before and after ultrasound in order to assess the impact of the ultrasound and how it's actually affecting the brain. And I'll explain this in the next slide. So it's really the question that we wanted to answer: how is focused ultrasound affecting the brain? First, we looked at cortical excitability and intracortical circuits. So how excitable is the region that we're targeting and the microcircuitry in that region? And to answer that question, we utilized transcranial magnetic stimulation, or TMS. This in and of itself, as I mentioned earlier, can be used as a tool for non-invasive brain stimulation, but for our purposes here, we were using it to measure cortical excitability. And then we also wanted to look at the local as well as global neural oscillations that are resulting from the focused ultrasound. And to answer this question, we utilized magnetoencephalography, or MEG, which is a state-of-the-art tool to assess really what's happening in the brain in terms of neural oscillations. So MEG records the magnetic fields that are generated from the normal electrical activity in the brain. And we performed recordings on our study subjects at rest and with a motor task. And this was relevant for us because we were specifically stimulating the motor cortex. So I'm just going to go over the three key findings that were garnered from our study. The first is that we were able to find that focused ultrasound actually does modulate how excitable the motor cortex is, and this is shown here. So in the first panel here, you can see in the teal box plot, there's an elevated measure of MEP, or motor evoked potential, which is our measurement of cortical excitability, after ultrasound relative to before ultrasound, and we don't see this in the sham condition. Similarly, using paired pulse TMS, which gives us a window of insight into the intracortical circuits, we see a change in intracortical circuitry after focused ultrasound, not before, and we also don't see this in the sham condition. So really what this told us was two things. Firstly, similar work was done by Dr. Robert Chen's group, so we were able to validate this in a separate cohort. And secondly, this demonstrated to us that focused ultrasound can actually have neuroplastic-like effects on the brain, at least transiently. The second major finding from our study is that we were able to show that focused ultrasound can actually alter movement-related activity in specific areas of the brain in frequencies such as the alpha frequency, again in very distinct regions of the brain, as well as beta frequencies at the whole brain level and at specific regions, typically mapping to motor areas as well bilaterally. So this was also interesting because we were able to show exactly how the motor circuitry is being altered by focused ultrasound to the motor cortex. And finally, we were able to show that LIFO actually modulates neural connectivity both on a local level and globally. When we look at the various oscillations of the brain, delta, theta, alpha, beta, and low gamma, we can see that the different regions of the brain, which are annotated on the periphery of the Surcos plot, their internal connectivity is altered, and how the different regions of the brain connect with each other, that's altered as well. And we were actually able to show a direct map of what's happening in each of these parcellated regions of the brain. So in summary, this is one of the first comprehensive neurologic studies looking at LIFO as a neuromodulation tool in humans, and we think that this will hopefully lay the groundwork for us to better understand how does this modality actually work. One of the main limitations from our study is the durability of the response. So in our particular study, we were able to show that the effects last for up to 60 minutes, but additional work will be needed for us to determine what the optimal schedule of administration will be in patient populations. And so when we go back to the gap that was identified where there's a need for accessible and effective forms of non-invasive brain stimulation, focused ultrasound is actually a very promising tool for non-invasive neuromodulation. It's safe, it's effective, and it's also highly scalable, which is relevant in terms of health-associated costs. And so we can envision in the future for highly selected groups of patients moving away from surgically implanted devices and surgical approaches to less invasive forms that would hopefully be just as efficacious. And in terms of future directions, we think that this represents a very exciting frontier in neuromodulation and a new innovative tool in neurosurgery. It can potentially be used for mapping or to predict the effects of DBS in selected patients, and maybe down the road this may be an alternative to deep brain stimulation for particular patient subsets or pathologies. And really one of the most exciting next steps is translating this into patients, and that's exactly what we're doing now. So we just started a pilot study of LifeFood to the motor cortex in Parkinson's disease patients to assess what the impact is on motor outcomes for these individuals. And we think that this can be generalized to various other groups within neurosurgery patient populations, including patients with movement disorders, post-operative rehabilitation in the neuro-oncology population, and strokes, as well as psychiatric indications. So I'll end there. I'd like to thank you very much for your attention and also acknowledge my supervisor, Dr. Andres Lozano, and Dr. Robert Chen, who we work very closely with, all of our collaborators and colleagues and our funding sources, and I'd be happy to take any questions.
Yes.
Yeah, thanks very much. That was really, really interesting. A couple of questions. In terms of translating this into clinical utility, could you expand a little bit more on, is this an effect only seen during the duration of the ultrasound, or does it last beyond that? And practically going forwards, is this, how portable can you make this? Will it be something that the patient, how will it attach to the head? How are you going to live with that? But it was a fantastic presentation. Thank you very much.
Thank you very much, Dr. Hutchinson. Thank you again. Welcome to Toronto. So to answer the first part of your question, I think in terms of durability of the response, I think this is very early days. This is kind of a technology that's really only emerged in terms of having a tool to do this portably over the past year or so. So I think we still need to determine what that would look like, whether it would be kind of having patients come for multiple sessions at a time, which would be similar to what we do now for transcranial magnetic stimulation, or even, envisioning something which is very futuristic, like a wearable device or something like that. So I think those are all possibilities, but there's still a lot more work that needs to be done in order to demonstrate the efficacy and the associated schedules.
Okay, great, thank you.
Thank you.
Thanks, Nardine. Fantastic work, really, really exciting. Can you talk about the challenges that the bone presents to ultrasound? Because as you know, the bone will attenuate a lot of the signal. How did you know that you were engaging the target that you wanted to target with transcranial ultrasound?
Yes, thank you very much for that question, Dr. Lipsman, an expert in neuromodulation focused ultrasound. So as you'll probably hear about a little bit more in the next talk, there's the concern of the skull density ratio as well, and how essentially the thickness of the skull and the architecture of the skull can affect how this is focused. And so for our particular transducer, there was a previous study that actually published this theta burst protocol by Dr. Robert Chen's group, and their work had actually demonstrated using this transducer that this was possible. But with high intensity focused ultrasound, it's different. Essentially, as you know, it involves focusing multiple beams through the skull. But this is a very small transducer that's on the order of a few centimeters.
Okay, thank you.
Great, very nice presentation.
Thank you.
So our last paper is Rishi Raghuram, and he is a master's student in Dr. Drake's lab, I gather, and he's going to be talking about an MRI-compatible, MR-guided, high-intensity focused ultrasound neonatal neurosurgery platform for intraventricular hemorrhage.
Hey, so you guys hear me right now?
We got him online here.
So I'll just share my slides. Everyone see the presentation right now?
Yep, we got it up there.
Okay, so I guess I'll get started then. All right, so thank you very much for taking the time to listen to my presentation today. And I'll be describing the development of our MR-guided high-intensity focused ultrasound platform for the non-invasive treatment of intraventricular hemorrhage. So IVH is a serious neurovascular complication that affects prematurely born infants. And IVH can result in clotting of blood within the ventricles, causing a buildup of cerebral spinal fluid. So IVH can also result in increased risk of early mortality for patients and also result in long-term developmental delays, permanent neurocognitive impairments, and cerebral palsy. So the current standard of care for IVH consists of surgically inserting a temporary ventricular reservoir for the intermittent removal of CSF and to decrease the intracranial pressure. Eventually, a permanent shunt is installed to divert the CSF into the abdomen. However, this surgical procedure is highly invasive and technically challenging due to the frail nature of the patient. And even for successful surgeries, there is the requirement for patient checkups and close monitoring of the shunt during their lifetime. So this warrants a better treatment option for patients that eliminates the current shortcomings, specifically one that can address the blood clots caused by IVH. So recently, high-intensity focused ultrasound, or HIFU, has been shown as a potential treatment modality that can address this issue. HIFU has been shown to lyse blood clots without the need for any additional thrombolytic agents. Upon acoustic cavitation, the violent formation and collapse of microbubbles within the thrombus reduces structural integrity from within, causing the clot to liquefy. So various MRI-guided HIFU devices and procedures have been approved for clinical use. However, these systems, like the Sonley table on the left and Exoblate Neuro on the right, are not optimized to treat IVH in neonates, since both require awkward patient positioning that would be unsafe for the thin and fragile skulls of the infants. Thus, there was a need to develop a platform optimized for that niche. And to address this issue, we have developed a neonate-specific HIFU platform that facilitates patient positioning by providing a larger treatment area through the patient's anterior fontanelle. The platform has 5 degrees of freedom to position the HIFU transducer and is based on an MR-compatible robot previously developed by our group. And lastly, a 3 Tesla Philips Achivia MRI is used for guidance during treatment. However, there were 2 major limitations of our platform that needed to be addressed before going forward. Firstly, the platform's HIFU targeting ability had to be optimized. Secondly, the platform's extent of clot lysis needed to be validated in an application-specific setting. So investigating both of these aspects will further the optimization of our platform and advance it towards a safe and effective treatment of clots in the brain of premature infants suffering from IVH. So to optimize the platform, we had 2 main areas of investigation in this work. The first was to optimize and assess the platform's targeting ability in a brain mimicking phantom. The goal in this case was to ensure the platform could hit an intended target location within a distance of 2 millimeters. And that distance was chosen because of the approximate ventricle dimensions of the patient, the HIFU focal point size, and the resolution of our MR imaging. The second aim was to validate the platform's clot lysis efficacy in a brain mimicking phantom. The goal in this case was to ensure at least 90% of the clot was dissolved after treatment. Since there are no defined values for the extent of clot lysis, we chose this 90% since it set a high minimum value that will allow a greater range of treatments for specific patient cases. So as I mentioned, the first aim of the project, or this work, was to optimize and quantify the targeting accuracy and precision in 3D space. So firstly, novel thermosensitive brain mimicking phantoms were developed to test the platform in a control setting. And these phantoms emulated the acoustic properties of a neonate brain. And after HIFU ablation, these phantoms, or this specific variant, changed opacity at the focal point with high spatial resolution and produced distinct contrast changes in the corresponding T2 weighted scans. So in the experiment, rectangular grip patterns were ablated into the phantom at specific coordinates. And the time-lapse video on the slide here shows the robot's path through all 35 points. And each point in the targeting assessment, ablation was conducted with a power of 100 watts, treatment duration at 30 seconds, and a rest time of 5 minutes to let the phantom cool down between subsequent points. And during this experiment, MR thermometry was used to monitor the ablation and cool down. After sonication, the intended targets were marked by inserting carbon fiber rods through a targeting assessment template, which allowed for consistent and repeatable demarcation of those intended targets over multiple experiments. Subsequently, the coordinates for the intended and actual targets were derived from the T2 weighted scans, and their centroidal distances were measured in 3 dimensions. The equations used to calculate positioning accuracy and precision were based on an ISO performance standard for industrial robots, and both were represented as vectors to quantify the accuracy and precision in 3 dimensions. And the overall targeting accuracy and precision of the robot were also quantified according to equations shown on the slide. So a total of 127 sonication points were conducted over 4 phantoms, and the positioning accuracy is represented on the scatter plot by the distance between the intended target, the blue dot, and the actual target, the black dot. Positioning precision in this case is represented by the elliptical 99.7% confidence interval. The corresponding positioning accuracy and precision are now shown on right in vector form, and these results, along with the scatter plot, show our platform has a high degree of accuracy and precision in all three directions. And these results yielded an overall targeting accuracy of 0.6 millimeters with a targeting precision of 1.2. A one-sample lower tail t-test showed this targeting error was less than 2 millimeters with statistical significance. So the significance of the first aim was these results displayed the platform's high targeting ability in simulated brain matter. A platform's targeting accuracy met our design objective of 2 millimeters, and importantly, these results show the platform is acceptable in the context of neonatal neurosurgery. So for the second aim of the work, the project validated the platform's clot lysis efficacy and the extent of collateral damage in a brain mimicking phantom. So firstly, higher fidelity brain phantoms were developed to provide a more realistic testing setting for this aim. So these phantoms have spherical cavities embedded, which acted as reservoirs for the blood clots and mimicked the ventricles of the infant. So in the experiment, an IVH model was created by clotting porcine blood inside these phantoms, and it's based on an in vivo IVH model we developed in our group. After 24 hours, the blood clots were lysed using the MRG HIFU platform, and the experimental setup is shown at the bottom left. The histotripsy parameters for HIFU are listed in the following table and are based on a previous optimization study we conducted. Following the treatment, the phantoms were cut open and the contents of the cavity, both the liquefied and solid blood, were drained into a wave boat. And the cavities were also flushed out with water to remove any remaining solid clot fragments and blood. The solid and liquid blood was then vacuum filtered to collect the remaining solid clot debris. And the mass of that remaining solid clot particle measured the remaining solid clot mass. So clot lysis efficacy was then quantified as the percentage difference in solid clot mass before and after treatment, according to the equation shown on the slide. And lastly, collateral damage was characterized as the extent of damage along the periphery of the cavities. So studies were conducted with deliberate off-target sonications to establish a benchmark appearance, and the figures on the slide show some of those benchmark appearances in our phantom. So in regards to the actual results of this aim, the clot lysis within the brain mimicking phantom was clearly observable via T2 weighted scans. And the following sets of figures show the progression during one specific experiment. The figure on the slide here is a pre-treatment scan of the phantom with the joint blood clot embedded. As you can see, the clot appears as two connected hypointense circles. After a single histotripsy sonication, the location of targeting is readily apparent by the new hyperintense region within the clot. And in the experiments, one half of the clot was lysed fully first. So this showed our platform could selectively target and treat the blood clots in the phantom. And this last image here shows a post-treatment scan showing that both halves of the clot were indeed lysed. So inspection of the phantom's cavities after the treatment did not indicate any collateral damage. So no damage was present in these phantoms that resembled the results from those benchmark off-target sonications from earlier. So a total of 9 experiments were conducted to assess the clot lysis efficacy. The bar graph here shows the percent of clot lysis in each experiment, and our results show the platform could achieve an average clot lysis of 97% with a standard deviation of 2.57. And using a one-sample higher tail t-test, these results show the platform could lyse more than 90% of a clot with statistical significance. So these results displayed our platform's clot lysis ability in simulated brain matter. And the platform's extended clot lysis met our design objective, namely that I could lyse more than 90% of a clot with no observable collateral damage. And lastly, the platform could selectively lyse a clot with a high degree of spatial localization. So we were able to fully lyse one half of a clot before moving on to the second. This would give a larger range of treatments, allowing clinicians a greater degree of freedom to optimize treatment for their specific patient cases. So before ending the presentation, I just want to conclude and summarize the results of this work. So the results demonstrated our platform's feasibility as a non-invasive treatment of the blood clots caused by IVH. Moreover, these results serve as an initial verification of the platform's systematic clot lysis ability and showed promise towards its final application in a neonate brain. 2 main aspects of the platform were investigated as part of the work. The first being the platform's targeting ability through brain matter, and secondly, the platform's efficacy at lysing blood clots was validated. Importantly, these results confirmed the goals were achieved. Namely, the platform could hit an intended target location within 2 millimeters and dissolve a blood clot by at least 90% with statistical significance. That being said, I'd like to thank my supervisors for their help and advice during the past few years and acknowledge the participation of my colleagues in the lab and thank them a lot for their help. And thank you very much for your attention during this presentation.
Excellent presentation, Rishi. This paper is now open for questions. Can you guys let me know if there's any online questions?
It's Abaya Kulkarni here. Can you hear me?
Yeah, I can hear you.
Okay, great. Great presentation, Rishi. This is a really important topic. You know, the issue of intraventricular hemorrhage or prematurity is a big problem for us in pediatric neurosurgery, and certainly the approach these days is to try to be more aggressive about it. So this is in line with that, being aggressive about the clot, yet at the same time being somewhat non-invasive. My question for you, it's more clinically based, and I understand that you're not a clinician, so this may be a challenge for you, so I apologize. But what do you think the actual benefits are of this potentially to the child, pathophysiologically and in their clinical management? You hinted, without saying explicitly at the beginning, that you think it'll reduce the incidence of hydrocephalus, which makes sense that it might. We don't know that it would, but it's possible. But the other issue is that we know that some of the blood breakdown products have deleterious effects on the developing brain. And so you're not dealing with that with this procedure. And so do you see that this could have a potential impact on brain development, or would it need to be used in combination with some of the other means that we already use, like CSF drainage and lavage?
That's a great point. So for the first half of the question, that is the main goal, is to reduce the hydrocephalus incidence. In terms of the actual products, the blood products after lysis, that's something we're still trying to investigate. So the next steps we're doing is we have an in vivo IVH model to assess that. So we want to use our platform using an in vivo survival study to see the actual effects afterwards. So that is something we are kind of worried about and need to investigate. And that's why also we use that 90% clot lysis. So we don't know the actual value where we need to treat. So it's something we are actually looking into as a lab. Yeah. Thank you for the question.
Great. We'll go to the...
Hi, Rishi. Neil Lipsman from Sunnybrook. Really incredible work, and really science fiction when you think about it. Using sound energy to lyse a clot through the skull in the human brain. So really, really exciting potential. Can you talk about how CSF and water in general acts like a heat sink? And if you're talking about high energy ultrasound, if you're talking about generating heat, water will actually draw heat away from your target. Is that a challenge, do you think, and how are you mitigating that?
So good question. So we're actually not using a heating treatment for the actual clot lysis. We're using acoustic cavitation. So we don't see a really big spike in the actual temperature. So we don't see that as too much of an issue, but it's something I guess we will look into when we do the in vivo animal studies. I hope that answers your question.
Yeah, absolutely. Thank you.
Thanks.
Great. Well, if there's no other questions, thanks very much, Rishi. So that concludes the paper session for the morning. I think we'll take a quick coffee break of about 10 minutes before we proceed on to the Gordon Murray lecture, and Dr. Failings will be doing the introduction for that.
Val just asked me to let you know that there's coffee and treats at the back.
hardware.
Okay, if I could kindly ask people to take their seats again. And perhaps if we could just, Terry, if we could kindly just get my slide up. Okay, well, welcome back. So it's truly an honor for us to welcome Professor Peter Hutchison from the University of Cambridge as our 2022 Gordon Murray lecturer. Professor Hutchison, or as he is known to his friends as Hutch, is really a leader internationally in the field of neurotrauma and academic neurosurgery. So he holds an NIHR research professorship at Cambridge, where he's the chair of the academic division of neurosurgery. He holds a number of leadership positions in the Royal College of Surgeons, and he's had incredible accomplishments. He's received numerous awards, including the Oliver Krona Award from the Karolinska, which is nicknamed as the Nobel Prize in neuroscience. He's had a number of tremendous accomplishments in the field of neurotrauma, but I think probably best known for his studies known as the rescue studies, and really he established the role of decompressive craniectomy in traumatic brain injury, and this has been recognized by very high impact publications, a number of journals, including New England Journal of Medicine, and his work has changed clinical practice in the field of neurotrauma. And interestingly and kind of cool, we had some discussions about this last night. He's quite an aficionado of Formula One racing, and is in fact the chief medical officer for Formula One in the British Grand Prix. And apart from this, he's a super nice guy and a real friend of Toronto. So on that note, Professor Hutchison, we would welcome you and ask you to please deliver your lecture on rescuing the injured brain.
Thank you very much, Dr. Failings, Michael, for the introduction. It is a true honour to be here and present this lecture in this magnificent setting, and I'd like to thank you, Michael, and Jim, Dr. for the invitation to come and speak here. I really enjoyed this morning's session. Some fantastic science and surgery going on, and congratulations to all of you. My lecture is entitled Rescuing the Injured Brain, and I'm going to take you through over the next 45 to 50 minutes on some of the work that we've been doing to try and improve the plight of patients who have this condition of traumatic brain injury. I come from a city called Cambridge, which is about 50 miles north of London. I've been truly impressed by the philanthropy and how you've managed to get donations in to build your service. We've not been so good at that recently, but in 1766, John Addenbrooke gave £4,500 to build a hospital, and that was the first Addenbrooke's hospital, which subsequently was built in the city and then moved out to the suburbs of Cambridge with the biomedical campus. In terms of the management of trauma, that changed about 10 years ago in the United Kingdom, where we have a number of designated major trauma centres, and we host the Major Trauma Centre for the East of England. The rule is that if you're within 45 to 60 minutes of a major trauma centre, you will be taken directly there. And interestingly, in London, there are now 4 hospitals designated major trauma centres, and the biggest of these is the Royal London Hospital in the East End of London. And Gordon Murray actually spent time there in the 1920s and received an FRCS London, so I think it's appropriate to acknowledge his visits to London and the training that he undertook there. You know, we find our region a challenge. From Cambridge, it's about 100 miles to the Norfolk coast. It's very humbling to come here and look at the size of Ontario, and I think we should stop complaining about getting patients from Norfolk when we have to address the challenges that you are clearly facing in terms of distance. This condition is a journey for a patient from the scene of an accident through a transition of care, emergency departments. Some patients require management in the operating room, intensive care for more severely injured patients, rehabilitation and reintegration into the community. We know it is a major cause of mortality, and we face the ongoing challenge of dealing with the morbidity and disability in survivors. There have been advances, but there do remain many unanswered questions. Of course, head injury and traumatic brain injury has a long history. We've known about this condition for thousands of years, and it was really Hippocrates, no head injury is too severe to despair of nor too trivial to ignore. And then we go through strange procedures of trephination in the Middle Ages. On the right there you see Percival Pott's device to elevate depressed skull fractures. Sadly, many of the advances of traumatic brain injury have been made during wartime, and again I think it's important to acknowledge Gordon Murray. He was sent with his 3 brothers to the First World War. Sadly, one of his brothers died, and Gordon himself was injured but recovered and went on to have a remarkable career. Advances in imaging, the CT scan. Michael mentioned my interest in Formula One, and I think a lot of the developments through motor racing have actually percolated through to safety advances in civilian road cars. And then more recently, we've been engaging the government in the UK. I think the acute management has improved with the Major Trauma Centre network, but the challenge we face is this is a chronic condition, and there are many people living with long-term disability, and it is how we manage their rehabilitation into the future that is absolutely critical. What about the cause of traumatic brain injury? Of course, you're already familiar with this. There are really 4 main causes. So road traffic collisions, falls, particularly in the elderly, and the challenge we have of people on anticoagulation. Assault, sadly, again increasingly common, and then a lot of interest in sports injuries, perhaps not so much severe injury, but the mild injury, the concussion, and the challenges that we have over this side of the Atlantic, particularly the NFL, and our equivalent, of course, is rugby, and how we deal with that problem. So I'm going to talk about 4 areas: the classification and the pathophysiology of this condition. And then the main part of the talk will be the intensive care management and some of the monitoring that we can undertake to protect the injured brain. Some of the clinical trials, particularly of surgical intervention, and then address the issue of traumatic brain injury beyond high-income countries. So the classification of traumatic brain injury, TBI can be classified in 3 main domains. So firstly, the mechanism, and we can talk about low velocity injuries such as falls, as I said, particularly in the elderly, an increasing problem. High velocity injury, road traffic collisions. And then severity, the Glasgow Coma score remains the gold standard for the assessment of these patients in the initial and ongoing stages. And a severe TBI is classified as a Glasgow Coma score of between 3 and 8, and that has a very precise definition of coma. And then in terms of the anatomy, broadly speaking, these patients will either have a focal mass lesion, a hematoma, which can sit within the extradural, subdural space, or within the brain itself, an intracerebral hematoma, or a diffuse injury, which its mildest extent, a mild traumatic brain injury, or a concussion, and then at its most severe end, what we call severe diffuse injury. So there you see on the left, this is an extradural hematoma. This is something that is healed by steel. We say that is something that needs operative management, and perhaps followed by the intensive care management. And then there's this cohort of patients with diffuse injury and contusional injury that require monitoring on the ICU. These patients have this common underlying pathophysiological issue. The brain is swollen. It is swollen in a tight box, the skull. The consequence of that is that the pressure, the intracranial pressure increases, and that results in a reduction in delivery of blood flow, oxygen delivery, energy failure, cell death, edema, and further swelling. And the goal of treatment of these patients is to try and intercept this vicious cycle. We measure intracranial pressure by putting a pressure transducer, so a hole through the skull, a bolt, a transducer goes through, and intracranial pressure normal is regarded as around 10 millimeters of mercury, above 20 as abnormal, and above 40 as severely abnormal. And there are many papers in the literature now which show a good correlation between sustained increase in intracranial pressure and poor outcome for the patient. The brain is an amazing organ. It has this tremendous ability to maintain its blood flow across a wide range of blood pressure, even between a mean BP of 50 to 160 millimeters of mercury. If the blood pressure falls, the brain will adapt, it will maintain its blood flow. The problem is, following brain injury, this concept of autoregulation is often impaired, and you can see then that a fall in blood pressure will result in reduction in cerebral blood flow, hypotension, and cerebral ischemia. So this autoregulation ability is often lost. If you look at the relationship when these patients are on the intensive care unit between their arterial blood pressure and their intracranial pressure, you can define periods of what we call the passive and active response, and this is when the patient is not autoregulating. In the autoregulating patient, if you increase the blood pressure, you will often reduce the intracranial pressure. That is potential therapy. If the patient is not autoregulating, increasing the blood pressure will increase the intracranial pressure. And now we've developed these computerized bedside monitoring, so this is continuous monitoring of intracranial pressure, the blood pressure, and you can see on the bottom there these periods of red and green, and that is the periods at which the patient is autoregulating or not. And this is now beginning to change our management, particularly in terms of the blood pressure control. So there's been many different works on algorithm, and Greg Horlick is in the audience. We've talked about various consensus statements in terms of how we manage these parameters, but our current standard is to keep the intracranial pressure at less than 25 millimeters of mercury, and that is achieved through these 5 stages of therapy of increasing intensity. So we start with simple things. We anesthetize the patient with propofol, we sedate them, they're nursed head up, we carefully control the blood gases, we avoid hypoxia, we avoid fever. We're quite aggressive and proactive in the use of ventriculostomies to drain CSF, even in patients with relatively small ventricles. That is a good way at helping to control intracranial pressure. And then through stage 3, we can augment the blood pressure in autoregulating patients with inotropes, osmotic agents, hypertonic saline and mannitol. Hypothermia is controversial. It does lower intracranial pressure, but you need to address the complications. I'll come back to that. And then I have a particular interest in 10% of the patients whose targets are not met by these first 4 stages of therapy, and in these one may consider a thiopentone barbiturate coma or a decompressive surgical procedure. But beyond ICP monitoring, which is really the gold standard, there are a number of other monitors that are increased in clinical utilization. So we can measure brain tissue oxygen by putting a brain tissue oxygen sensor directly into the brain. And this is the BOOST 2 trial. So David Congo and colleagues randomized patients to a protocol based on ICP monitoring alone or ICP monitoring in conjunction with brain tissue oxygen monitoring. And if you add this brain tissue oxygen monitor, you can detect and treat periods of cerebral hypoxia. And I think of these additional monitors, brain tissue oxygen is probably the one to go with following ICP as your first additional monitor. The other technology that we've been interested in for several years now is this technique of microdialysis. This too is a probe that's placed within the brain. What does it measure? It measures brain chemistry, so the delivery of glucose and how it is metabolized to pyruvate, lactate, and then we can measure other important substrates and metabolites such as glycerol and glutamate. It's a pump, contains a fluid. The fluid presses into the brain through a catheter. This is where chemicals diffuse into the fluid, which then comes up through another catheter connected into a vial for analysis. So taking you back to the days of biochemistry, we can measure how glucose is delivered to the brain, how it is metabolized by glycolysis to pyruvate. This is where it enters the citric acid cycle, where energy is generated in terms of ATP that occurs at the mitochondria. But we know that
in the presence of hypoxia or mitochondrial dysfunction, that pyruvate can be preferentially metabolized to lactate, and this marker of lactate compared to pyruvate has become the signature of chemical derangement following brain injury, and that's something we can now measure with this microdialysis technology. We've looked at over 200 patients in our initial series, and we showed strong relationships between the lactate-pyruvate ratio in terms of outcome. And then we've looked at a number of therapies and how they can improve brain chemistry according to that algorithm. So the gold standard now is that we place a 3-port cranial access device, so a bolt with 3 channels, and through this we transmit the conventional intracranial pressure probe, but we also insert a brain tissue oxygen sensor and the microdialysis catheter, and that gives you a very comprehensive focal multimodality monitoring system. Recently, we've looked at the data in over 600 patients with TBI to really try and characterize the metabolic dysfunction, particularly in relation to time, and you can see there on the top right the trend in lactate-pyruvate ratio for patients with what we define as a favorable and an unfavorable outcome. But of course, it is much more complicated than that. This goes beyond intracranial pressure. We can look at changes in LP ratio with normal pressure, high pressure, normal glucose, low glucose, autoregulation and dysautoregulation. And it is a very complex microenvironment. But what we've tried to do is for each patient is define in terms of a more precision medicine approach different neurometabolic states. We can have intracranial hypertension, we can have oxygen delivery failure, failure of glucose delivery, and then this concept of mitochondrial dysfunction that I think we're becoming increasingly aware of. So using the monitoring, the LP ratio, the ICP, and the brain tissue oxygen and the glucose, we can now define these signatures of each of these different pathologies. Mitochondrial dysfunction, I think, is something that is becoming increasingly apparent. It is injury to the mitochondria. This, of course, is the powerhouse of ATP production. And in the electron transport chain, it is complex 1 that we feel is often most vulnerable in terms of injury. Succinate is an important substrate for complex 2, and there's this concept that you can actually rescue mitochondrial dysfunction by administering succinate. As well as microdialysis monitoring what comes out of the brain, we can actually label substrate. We can give labeled glucose, labeled succinate, and see how it's metabolized, detected by nuclear magnetic resonance. So we can really begin to get a feel on how substrates that we administer are actually detected and utilized by the brain. And we've been doing that with glucose predominantly. But there is quite a lot of interest in succinate. We can give succinate down the microdialysis catheter. It's a 13C label, and we've been able to show that that is actually taken up by the brain, and we've been able to label some of the metabolites, fumarate, malate, glutamine, to show that this succinate that we're giving is actually taken up and metabolized. But beyond that, exogenous succinate administration does also improve the lactate-pyruvate ratio. It's early days, but this may be succinate therapy as a potential rescue for mitochondrial dysfunction. So if we go back to our treatment algorithm, we've now added beyond the ICP threshold of 25, brain tissue oxygen at 15 millimeters of mercury, and the microdialysis lactate-pyruvate ratio of less than 25. This is our adult algorithm. We are beginning to apply this technology now to children, and we're just beginning to add microdialysis and brain tissue oxygen in our pediatric ICU. So the algorithm becomes a little bit more sophisticated, where we don't only look at ICP, but we look at the brain tissue oxygen. If that is less than 50 millimeters of mercury, we will consider augmenting that, firstly by increasing the blood pressure and the cerebral perfusion pressure, and if necessary, increasing the FiO2. We see periods of very low brain glucose on microdialysis. We will now supplement this with increasing the plasma glucose by administering dextrose. And if all the other monitoring is corrected, but the parameters remain deranged, then this mitochondrial dysfunction concept comes in, and in these patients we are now administering the succinate. I want to now talk about the second part of my talk, which is really some of the trials that are undergoing in TBI and the quest, what we call the quest for evidence for treatment. I mean, you will all be aware of, I think, the universally disappointing approaches to the drug therapy for this condition in terms of pharmacological management. I'm not going to go into that in detail in the interest of time, but sadly many agents that were so promising in the laboratory and animal studies have not percolated through to success in the clinical arena. There are other approaches. So hypothermia is controversial. The RCTs of hypothermia have also been disappointing. It does seem to be a good means of reducing intracranial pressure, but patients under hypothermia have a number of complications, particularly in relation to coagulation and infections, particularly chest infection. We are also looking at other clinical trials. There's a trial of osmotic therapy, so mannitol versus hypertonic saline, trials of anticonvulsant therapy and antithrombotic therapy. This again nicely relates back to Gordon Murray. He was a pioneer of giving heparin in surgery, one of the first surgeons to do that, and I think very much led surgical practice. But we don't know when we should be starting antithrombotic prophylaxis in patients with TBI. There is a risk of contusion expansion, but we have a number of patients with DVTs and PEs, and I think that's something that requires further investigation. I have a particular interest in surgical trials for traumatic brain injury. So these are the common surgical pathologies that you'll be familiar with. So on the left, we have an intracerebral hematoma. We then have diffuse brain injury, acute subdural hematoma, and chronic subdural hematoma. And generally, the surgery that we perform for these conditions is well established, but the indications for that surgery can be quite complex and the decision-making complicated. This patient has a traumatic intracerebral hematoma. The question is that something that we should evacuate via craniotomy, or is that something that is better observed, the patient ventilated, an ICP monitor? And David Mendelow, colleague in Newcastle, randomized patients with this sort of intracerebral hematoma to early surgery with evacuation of the hematoma compared to ongoing conservative treatment. For logistical reasons, that the study was stopped early. There were issues in terms of funding and where these patients were recruited. But what he showed was that there was no doubt a marked reduction in mortality with early surgery and a trend to what we call favorable outcome. But I think that there does need to be more done in terms of defining the indications for surgery for this sort of mass lesion. Decompressive craniectomy is an operation that's been around for many decades. The brain is injured, it is swollen in a tight box. We can open that box. That is called a decompressive craniectomy. The bone is removed and the scalp is placed back over the brain. That can be what we call a unilateral decompressive craniectomy, a hemicraniectomy, where we remove one half of the skull. The classic indication for that is an acute subdural hematoma. The alternative surgical approach is what we call the bifrontal decompressive craniectomy, where we will remove the frontal bones from the coronal suture down to the floor of the anterior cranial fossa. And this is the general indication for diffuse brain injury. If you're going to do this operation, you need to, what we call, go big or go home. This is a 12-centimeter diameter craniectomy. If the craniectomy is too small, you will come across a number of complications, and this rejoices in the name of fungus cerebri. So we need to do large craniectomies if we're going to do that. Of course, you are then faced with the issue of subsequent skull reconstruction, this operation cranioplasty, and there is controversy both in terms of the timing of cranial reconstruction, weeks versus months, and also the nature of the material. It is possible to replace the bone flap stored either in the freezer or in the patient's abdomen, or I think most people in the UK now are moving towards these synthetic cranioplasties, titanium or PEEK. So the quest for evidence for this operation revolves around three relatively large randomized trials, two for what we call secondary decompression. So this is raised intracranial pressure with diffuse injury that is not controlled by the first 4 stages of therapy. And then there is a second trial of this rescue acute subdural, which is primary decompression that I'll come back to. So the first of these trials, DECRA, this was a trial which randomized patients to decompressive craniectomy with an ICP threshold of 20 millimeters of mercury for 15 minutes in diffuse injury, and was led by Jamie Cooper and Jeff Rosenfeld in Melbourne. They screened nearly 3,500 patients, randomized 155, and what the results showed is that there was no difference in mortality between patients randomized to a decompressive craniectomy compared to standard ongoing medical management, but there was a higher rate of unfavorable outcome in those randomized to decompressive craniectomy to standard care. So the results were worse in those who'd had the craniectomy. If you look at some of the data from the study, interestingly, this is the ICP tracing in patients in the DECRA study in the standard care versus the decompressive craniectomy groups. Our ICP threshold you see of 25 is shown there on the slide with the red circle. What decompressive craniectomy achieved in the DECRA trial was a reduction in ICP. ICP control was better with decompression, but if you actually note the ICP tracings in the standard care patients, these patients were managed well medically. They were below standard ICP thresholds. Decompression had perhaps additional complications, and this may explain why the patients were doing worse. Our trial of decompressive craniectomy, the rescue ICP trial, was slightly different to DECRA. We performed this operation as a rescue, as a last-ditch attempt. We've tried these other medical interventions, a ventriculostomy. We're still not winning. The ICP is above 25, approaching this stage 5 of treatment. And we used to debate, is this somebody for a barbiturate coma? Is this somebody who should undergo decompressive surgery? So the hypothesis for the rescue ICP study is that decompressive craniectomy can improve outcome as a last-tier therapy for refractory post-traumatic intracranial hypertension, and we randomized patients when their ICP was above 25, they'd had all the other treatment, and that was into either what we called advanced medical management, where we could give the barbiturates, the thiopentone, in one arm, versus surgical management in the other. We made 2 mistakes in the design of this trial. The first mistake we made was the timing of the primary endpoint. Classically, these head injury studies have a 6-month outcome. I think we all recognize now that that is too soon, and we need to be following these patients longer. The other issue, and I think in fairness it was related to funding, was we really didn't collect enough of the cranioplasty data, but perhaps I could come back to that. Head injury, traumatic brain injury outcome in trials and clinical practice is now often defined by what we call the extended Glasgow outcome scale. This is an 8-point scale which extends at its best end to upper good recovery. This is no injury-related problems, and to the other end of mortality. And between this, you have a spectrum of survival with disability, the worst being the vegetative state, unable to obey commands. Severe disability is divided into 2 categories. Lower severe disability is somebody who is dependent on others for care. These are patients in rehabilitation centers, nursing homes. Upper severe disability are patients who are independent at home for at least 8 hours. So they do need some assistance, maybe at the beginning of the day, at the end of the day, but they are independent at home for at least 8 hours. And then we get better through moderate disability and lower good recovery. Rescue ICP randomized over 400 patients, and we're really grateful for centers in Canada that randomized patients in this trial. It was powered to detect a 15% difference in outcome at the level of upper severe disability, the independent at home or better. The primary outcome at 6 months was striking in that it showed a very marked reduction in mortality with surgery around 27% compared to 49% in the medical group. But the surgical patients had a higher rate of vegetative state and lower severe disability and upper severe disability or better than the medical patients. But when you follow these patients through to 12 months, you see a shift and improvement in the surgical patients moving towards the better outcome category, such that 50% are in this USD better or USD or better category. I think this is the most useful analysis that came out of Rescue ICP. This is what we call the what if, and I think this has helped with decision making. If you take 100 patients in this situation and you undertake a decompressive craniectomy, what's going to happen? What happens is that you will save 22 more lives. And of the categorization of these survivors, of the 22, we have 5 in the vegetative state category, 4 in lower severe disability, and 13 in the upper severe disability or better. The challenge, of course, is going forwards is can we try and predict which patients are going to end up in the green area compared to those in the red and the yellow area. So since Rescue ICP was published, we've had some time to reflect on it, and the last few years or so, we've felt, well, actually, how can we use this data? Where are we now with Rescue ICP? So I think the data's informative. There is no doubt that this is class 1 evidence that it is life-saving. It reduces mortality. And we know that at 12 months, patients with surgery continue to improve, with 50% or so at least independent at home versus 32% in the medical group. But I think we have to be conscious that this operation is generating patients who are in these lower states of disability. So the choice to provide this operation has to be individualized. We've tried to think a bit smarter. Why are some of these patients doing well and some are doing not so well? I think imaging has a role. These patients were triaged on the basis of a CT scan. We know that a number of patients, when we perform an MR, have a significant brainstem injury that is not diagnosed on CT. If you perform a decompressive craniectomy in a patient with a severe brainstem injury, saving high pressure and their cerebral hemispheres will not help. Their prognosis will be defined at the level of the brainstem. So I think that is something we need to look at in more detail. And we also need to be a bit smarter, I think, in terms of the timing of skull reconstruction. The improvement between 6 and 12 months, I think, is in part due to the skull being put back. We do, I think, use this data to try and inform our discussions with families. And what I've learned over the last few years is these trials are defined as positive or negative. The patients are in unfavorable or favorable outcome categories. But again, this is something we probably need to move away from. What is satisfactory for one family may be not satisfactory in another, and different patients and different families will tolerate different levels of disability, and I think we need to do a lot more work in terms of quality of life in these patients beyond the Glasgow outcome score. So try and move away from favorable, unfavorable. What can we say is that DECRA showed these early decompressions before other treatment options is not indicated. As a rescue intervention, it reduces mortality. Current evidence is that about 40% of the survivors are dependent and about 60% of the survivors are independent at home or better. And it takes a long time, over a year, for the full benefit to declare itself. Martin Smith chaired the Data Monitoring Committee. He made this very profound remark in an editorial that decisions to recommend this operation must always be made not only in the context of its clinical indications, but also after consideration of an individual patient preferences and quality of life expectations. And I've been amazed how some families who we would perceive as maybe the outcome is not what we would want or what we anticipate, but actually their quality of life and the way they interact for them works. For others, it does not, and we need to do more. Briefly, I just want to mention the acute subdural. So this was a study that we finished recruiting. We're analyzing the data. This is a challenge because this is acute subdural hematoma, and the patients are randomized in the middle of the operation to a decompressive craniectomy, putting the bone flat back or leaving it out. Again, thanks to many, many centers internationally, North American centers and centers elsewhere for their contribution to rescue acute subdural. We hope to get the results out in the next few months. So what have we learned from the trials? The STITCH trial showing that surgery for traumatic intracerebral hemorrhage reduces mortality with a trend towards an increase in favorable outcome. DECRA showed that early secondary decompression for diffuse injury with this relatively lower ICP threshold for 15 minutes are no difference in mortality and an increase in unfavorable outcome. And rescue ICP showed that this later secondary decompression for diffuse injury and mass lesions for refractory ICP reduced mortality with a spectrum of outcome in the survivors and an improvement in the outcome from the 6 to the 12 months. We put together a consensus statement, and Greg was involved in this. We held this in Cambridge, and we had a number of collaborators. I think what became apparent was that this operation was very much being focused in high-income countries. And I think what we need to be aware of, and I just want to spend the last few minutes talking about this issue of head injuries in low and middle income countries. About 89% of head injuries are occurring in low and middle income countries. About 90% of publications are coming out of high income countries. And in 2017, the UK government committed a significant proportion of GDP to overseas development assistance, and much of that went into health, and we were fortunate in being invited to host this NIHR Global Research Group on neurotrauma. And a lot of that relates to prevention. If we're going to make a difference in terms of public health, we have to go down this route of trying to stop the accidents happening in the first place. So this is Lawrence of Arabia on his motorbike. He died in 1934, and that's Hugh Cairns. So if we move from the First World War to the Second World War, and in terms of bringing in helmets during military times, and now where are we with helmets? And this is a picture I took in Chennai in India, where you can see the issue. You know, the Indian government, they introduced the people's car for India, takes the family, but when you can get the whole family on the motorbike, why do you need the car? But you know, these are quite shocking, where you have dad there who's the only one wearing a helmet and there's 4 people on a motorbike. So I think we need to get wiser in terms of prevention. A couple of months ago, we published what was called the GENOS study. Again, this was an international collaborative looking at differences in management of surgery for traumatic brain injury in high versus low middle income countries. And we studied records, over 1,600 patients from 159 hospitals in 57 different countries, and divided globally into what we call the Human Development Index, so very high, so that will be North America, Europe, Australia, in high parts of Latin America, parts of Asia, medium and low income countries. Tony Fagaji, who's a colleague we work with in the NIHR group in Cape Town, he loves to see the world like this, and I think this is a really good way of looking at the world. The world is a globe. You could actually look at it either way, and he has this map, and it puts sub-Saharan Africa at the top, and I think that's a really good reminder in terms of how we've really got to help this condition in different parts of the world. The median age was 35 years. The oldest patients were in the very high tier and the youngest in the lowest tier. In North America, Europe, the commonest cause of this injury is now falls, particularly in the elderly. But in other parts of the world, road traffic collisions are a pandemic. It is becoming a real issue. The overall mortality was 18%. Interestingly, the odds of mortality relative to the very high tiers were greater in the medium and the high tiers, but less in the low tiers. And I think you can read into that many patients who could be saved are not actually reaching hospital in many countries. This is the type of surgery that is conducted. So again, in North America and Europe, the commonest operation following head injury is a supratentorial acute subdural hematoma. In other parts of the world, it is an extradural hematoma, and you can see some of the surgery, the only surgery that's really being offered in parts of Africa is, for example, depressed skull fractures, and a median time of injury to surgery to 13 hours is clearly far too long. Finally, how can we try and help beyond prevention and surgery? We need to be smarter with technology. CT scan is not available in many of these countries. This is the infra scanner, so this is infrared spectroscopy where we can actually try and diagnose blood clots without a CT. Ultrasound, optic nerve sheath diameter, is a surrogate measure for intracranial pressure. This ultrasound does not need to be expensive. That is the Philips Lumify. It is a simple probe. You connect it to your smartphone. For ultrasound indications for brain injury or other indications, general surgery, it is a potentially valuable technology. And finally, how do we measure outcome? The extended Glasgow outcome score in the UK, you post it. In sub-Saharan Africa, many people do not have a postal address. People said, Hutch, why don't you, let's do an app, smartphone. I said, people have mobile phones, they do not have smartphones. That is the Nokia brick phone. It's amazing, it's cheap, and we can actually get the SMS text to give us the Glasgow outcome score. That we designed for sub-Saharan Africa. Where is this used now? In the UK National Health Service. So some of this technology that you think is going to be for low-middle countries actually come back to home. We have an ongoing registry, GeoTBI, to beyond GENOS, and we've also got an interest in the new group in terms of spinal cord injury that I've been discussing with Michael. So to conclude, I've talked a bit about the classification of pathophysiology, ITU management and monitoring, and a more precision-based approach, some of the clinical trials, but I think going forwards we really do need to continue to address the challenges in global neurotrauma. I'd like to acknowledge my colleagues, investigators in the trials. The NIHR, the UK government funder for the NHS, has been tremendous in funding surgical research over the last decade, and huge credit to the Centre TBI collaborators, that's a big European consortium, and the BNTRC, the UK neurosurgical residents have got together and they form what we call this trainee collaborative, and I know there is a Canadian collaborative as well, and I think they've been discussing joint projects. My colleagues in Cambridge, the ABI group, many people involved in these studies in Cambridge, and finally, that is my contact details, and I think appropriate to acknowledge, and I have read a bit about Gordon Murray and the contribution which he made, which has been absolutely amazing, so it's been a real honour to present this lecture, and I'd like to acknowledge the University of Toronto, the Department of Surgery, and for the very kind invitation to give this lecture. Jim, Michael, thank you very much.
Well, Professor Hutchison, a fantastic lecture, a real tour de force. I have time for a few questions, and I might take moderator's prerogative and ask the first question. And Hutch, you alluded to the shifting demographic that we're seeing, particularly in developed economies, and in neurotrauma and trauma in general is starting to become a disorder of the elderly. And in the past, a lot of our protocols were driven by treating younger individuals, where one tends to be very aggressive and proactive. How do you see things shifting here with regard to this issue?
Yeah, I mean, it's a huge challenge. If you look at the demographics, we know that the population is aging, and we are seeing more of what we call it silver trauma in the UK, and we are seeing this cohort of elderly patients with falls, acute subdurals, other neurosurgical pathology, other pathologies, and I think we have to go with it, and the prognostication, we need to do more, but we're being quite proactive with these patients. I think as over the last few years, we're seeing more of these patients, we're treating them very actively, very aggressively, and we are having good outcomes. The other thing we've learned that it's not only chronological age, it is biological age, and some of the work that's done on frailty index, both in the spine and brain, I think has been really important. But certainly we are getting more elderly patients, we are having good outcomes with many of them. But it's an issue that we're all going to have to face, yeah.
Hutch, congratulations on a spectacular talk. I wanted to ask you a little bit more about Rescue ICP. It's a fascinating, complicated study that seems to have equally armed the proponents and the detractors of decompressive craniectomy. Curious for a little bit more in terms of how that study has changed your practice and what you think is the road forward in trying to figure out when we should do this.
Yeah, so I mean, it certainly it's certainly changed our practice, and I think since Rescue ICP we are doing more decompressive craniectomies, but I think we have got a bit wiser in terms of the indications, and I think you do need to look very carefully, particularly we are getting MRs in these patients now, and as I said, the brainstem or really severe devastating injury is not somebody to decompress. This is not a panacea, this operation, and I'm not an advocate of decompressive craniectomy. My view about Rescue ICP was to provide the data and to give the results out there and for people to make their own decisions. As I said, this isn't about favorable or unfavorable. It's about trying to provide as much information to guide decision making.
Dr. Rucker?
Yeah, Hutch, great. Gordon Murray lecture, thank you. And I'd be interested in your thoughts on the paper by Randy Chestnut and his group looking at the South American cohort published in New England Journal about the use of ICP monitor in severe traumatic brain injury, where they didn't show any difference in outcome between an ICP monitored group and a group that was monitored with best critical care management. I know that's been discussed enormously. I appreciate your opinion on that. And then secondly, decompressive craniectomy, how about timing of that operation? You're using it, it's from a lot of the studies, way down the algorithm. But what if you had machine learning, radiomics, and you could look at a CT scan and say, this patient needs it now, and you get to it before 2 or 3 days go by, in which case there's already been the injured brain that's suffered the consequences.
So Randy Chestnut's study, Best Trip, is published in the NEJM. It was randomizing patients to management with an intracranial pressure monitor or best treatment without a monitor, and the results were interesting. It showed in that population that you could manage these patients well without an ICP monitor. I think the demographic of the patients, 45% of these patients did not go to hospital by ambulance. So I think there were differences, but it was a nice example of showing there is a way you can manage these patients safely using these conventional approaches. So it was controversial, we know that, and I think, I think we just need to be aware, if you look at the inclusion criteria, the sorts of patients in that study, the management, I don't think you can translate the findings from South America in those centers into perhaps our practice. So again, it's something to be aware of. The timing of decompressive craniectomy is controversial. My worry, we went for it quite late, and the reason we did that, I was concerned before we randomizing, we were doing a lot of decompressive craniectomies, and the patients were doing quite well. And I thought, my goodness, did we really, really need to do that? That's a big operation. And I think some of the issues with DECRA may be related to that. Maybe these are patients who didn't really need a decompression. They could be managed medically. So we went for this sort of, it was a 12-hour window. ICP's above 25, you're not controlling it. Then we would go for the decompression. But Jim, your point about whether we can predict which of those patients is going to get into that boat would be really, really helpful. And whether we can do that retrospectively, we may well be able to do that. We could look at the Rescue ICP cohort, but some sort of sophisticated machine learning approach, the lovely work we saw yesterday with the way we can evaluate CT scans by computer, much more than we can process with the human brain, would be a really, really amazing way forward. So Jim, thank you for raising those 2 points.
I just wanted to ask, is the lactate pyruvate ratio that you talked about, is that just a research tool, or is that actually in active clinical practice, and are you using it? And you alluded to the fact that it, you may be, if the ratio is rising, you're obviously getting more anaerobic metabolism, and those patients you need to intervene on. Has that been used as an index in terms of decompression craniotomy? Thank you.
So two great. So the lactate pyruvate ratio, we used it in research. So we had to fund the microdose catheters out of grants. It had an IRB, and then about 6 or so years ago, it became standard of care. So in our center, we use it. It's funded by the NHS. If you talk to the manufacturer of microdialysis, it is currently used in 140 hospitals worldwide, many in research, but I think there are a number of hospitals in Scandinavia who are beginning to use it again in terms of clinical management. The problem is it's cumbersome. It's got the pump with the fluid, it goes in the catheter, you have to collect the vial, the nurse has to put it in the machine. So I think what has held microdialysis back is it needs to be smarter. We need to get the technology without the fancy chemicals, the pump, and just try and get the number on the screen of the lactate pyruvate ratio. I think with that it will fly. We do use it in terms of our decision making for decompressive craniectomy. We look at the ICP, the brain tissue oxygen, the LP ratio. If the ICP is maybe at 25, going above 25, but the other parameters are stable, I think we could hold off on that. When the ICP is high, the oxygen is low, and the LP ratio is climbing, that would push us into the decompressive craniectomy scenario. So, thank you.
And, Dr. Scully.
Yeah, thank you very much for a clearly expressed, brilliant presentation. I was interested in the technology described short of a CT, where you may be able to define what's going on. Not everybody has a CT or easy access to it. How is that technology developing, and would that be a very useful screening tool in terms of referring somebody urgently for a CT scan?
So that this spectroscopy device, it'll detect a hematoma within 3 centimeters of the skull surface. We're currently trying to look at the specificity and sensitivity, but we are picking up surgically significant hematomas in conjunction with CT. So these trials are undergoing in Colombia and Guatemala. I think in terms of high-income countries, access to CT is so available, they may have less of a role, but in terms of low and middle-income countries, great potential. What we found with CT, sadly, is it's often available in these countries, but people can't afford it. Or they may only be able to afford one CT and not serial CT. So I think this sort of portable technology, the ultrasound device, if we can get that out there, it will make a difference. Yeah.
Great. Well, on that note, I think we'll close out this session. Professor Hutchison, thank you again for a magnificent lecture. Thank you. Thank you. Perfect. Okay. So I'll call on Dr. Aaron Nauth again to chair the next session. And this year we did the e-posters electronically, and we actually had judging the past week. Just want to acknowledge the judges that I thanked in the previous slide. And this morning and then this afternoon, we'll be having the various prize winners deliver oral lectures based on their e-posters. Aaron.
Okay, thank you, Dr. Failings. Good morning again, everyone. So we're going to be having the winners from the e-poster presentations present. We have the first cohort presenting this morning. The first speaker is Rashmi Nidadur from the Surgeon Scientist Training Program, who took the third prize for Surgeon Scientist Training Program for her poster entitled Machine Learning to Identify Predictors of Heart Transplant Survival.
Thank you for this opportunity to present at GallieDay and to the Department of Surgery and SSTP. My name is Rashmi. I'm a PGY4 in cardiac surgery, and I'm presenting machine learning to identify predictors of heart transplant survival. So previous studies predicting survival after heart transplantation have shown that there are multiple phases to survival amongst these patients. And this is impacted by a series of different predictors that are impacted by recipient variables, donor variables, and operative variables. And we can imagine that there's actually a relationship between these variables, but also a time-dependent relationship between mortality and these variables. To that end, we had a three-parted objective. First, we wanted to model early and late phase mortality using recipient, donor, and operative variables. We then aimed to understand the time-dependent relationship between these variables and heart transplant survival. We then looked to identify the important predictors that impact early and late phase mortality. This is our overall study workflow. We included 589 patients that had heart transplantation at the Toronto General Hospital from 1987 to 2017. There were a total of 26 variables that were included in the modeling. We divided the data into a 75% training and a 25% test set. The overall event rate amongst our cohort was 15%, and in keeping with the phasic nature of mortality, 70% of the mortality took place within the first month after transplant. Using the 75% training set, we performed data cleaning, some imputation and normalization, and subsequently trained 2 models, logistic regression and random forest. Log-reg is our standard predictive analytics that we see nowadays in clinical predictions, and random forest is a machine learning algorithm. We use machine learning in this particular circumstance due to the data-driven nature or the probability-driven nature of our analytics, as well as the significant collinearity that one can imagine from the 26 predictors that we included. There are a total of 8 models that were generated, 5 models that predicted early mortality, and 3 models that predicted late mortality. We tested our models on the held-out test set from our data splitting. For model evaluation and interpretability, there were a few metrics that were measured. First, we compared the model performance using AUROC as well as sensitivity. Because machine learning models have been criticized to be black box, we performed a interpretability or post-hoc interpretability step using Shapley additive explanations, which gives us a sense of the predictor's importance, both in direction and in magnitude. We then performed a trajectory analysis by studying the importance of donor, recipient, and operative variables and their relationship with mortality over time. Here we see the results of the AUROC and sensitivity analysis comparing log-reg and random forest. When we look at the one-day model, we can see that the AUC of random forest and logistic regression were pretty similar, though random forest had higher sensitivity. But what we see, importantly, is that as data accrues and as time accrues, random forest is able to outperform logistic regression both in AUC as well as sensitivity. Log-reg basically has the same performance over the course of time versus random forest is really able to capture the time relationship that I am trying to capture with this modeling. In addition, when we look at the net reclassification improvement, we can see that early survival at 1 day, we see that there's very, very minimal actually net reclassification between random forest and logistic regression. However, with the accruing of time and data points, we can see that random forest is really able to improve reclassification in patients post-heart transplant. Here we see the trajectory analysis performed. Here we can see that we divided out the variables into recipient, donor, and operative variables. On first glance, we can see that recipient characteristics are the most important to predict heart transplant survival, followed by operative variables, and finally by donor variables. Amongst the recipient variables, the most important variables that we can see are predictors of recipient renal failure. This variable has importance throughout the course of the patient's life. Variables that address rejection as well as chronic immunosuppression have limited impact on early survival, however, gain a lot of importance over the course of time. Amongst the donor variables, a really important factor has been the predicted heart mass ratio, and this is a marker of heart size mismatch between the recipient and the donor. We see that in early survival that it has a pretty significant impact, however, loses importance over time. So to summarize the results, when we look at time-based modeling, we can see that random forest had greater ROC and sensitivity compared to logistic regression, with incremental gains in the late phase mortality predictions. When we look at the trajectory analysis findings, we can see that in early phase, donor, operative, and recipient characteristics are important. However, donor and operative features lose importance over time. Predicted heart mass ratio was the most important donor variable. Recipient variables are, of course, remain important for both early and late phase mortality, and an important variable is recipient renal dysfunction as an important predictor for both early and late survival. This methodology informs risk mitigation in patients by identifying the contributing factors to mortality, but also the timing in which these factors and modifying these factors would be most effective. For patients that are at higher risk for early mortality, risk mitigation should really involve all three variables. However, for patients that are at higher risk for late mortality, risk mitigation can involve only the recipient, and we can perhaps prioritize recipient characteristics for these patients. Recipient renal dysfunction patients are at high risk for mortality regardless of the phase in question and should be managed cautiously. The complicating factor here is that as we know, the cardiorenal axis is a really important axis that we need to focus on. A lot of patients that have pre-transplant renal dysfunction, it is hard to distinguish between those that have primary or irreversible renal dysfunction and those that have cardiorenal syndrome. As it currently stands, when we speak to our transplant nephrologists, basically patients that have renal dysfunction are prohibited from heart transplantation. Predicted heart mass ratio was the most important donor variable for early mortality. The way in which this data point can be used is that amongst patients that have other risk factors, such as renal dysfunction or risk factors that increases operative time and complexity, we should have a lower tolerance for heart size mismatch in these patients. In addition, another way to use this data point would be that amongst patients that show signs of clinical deterioration in the later phase, we can prioritize recipient variables over heart size mismatch during clinical evaluation. In conclusion, machine learning, specifically random forest, is able to better model heart transplant survival compared to traditional statistical methods and should be considered as a form of survival modeling to identify patients at risk. This type of analysis recognizes that there's a time-based relationship for heart transplant survival and should be appreciated when evaluating a patient. Thank you for your time.
Excellent presentation. So we'll open up this poster for discussion. The first mic.
Yeah, I echo that as well. Machine learning is a new method of statistical analysis. I don't understand it obviously as well as you do, and you're one of the first people that I've ever known who's done it. All clinicians want to have that crystal ball. If I do this treatment for the patient, can I predict what's going to happen to the patient? And I think this brings us a step closer to that. I had two questions. One of them is, how do you choose the initial prediction? You need an expert in the area to help you to do that. And the second thing is, how do you, in your model, change it, or how does it change when you have changing patient characteristics or new therapies that weren't previously available?
Could you please repeat the first? There's an echo here, so I can't hear.
Sorry about that. How do you determine the 26 variables? In other words, when machine learning, more variables you have, the better it is, but how do you choose those?
I see. Thank you for that question. Yeah, this is an interesting point because you can really only include variables that, one, you measure or have previously known to have some sort of value in heart transplantation. In this modeling specifically, I didn't perform a whole lot of what we call feature selection. So what we typically do when it comes to traditional statistics is that we pick what we think to be important variables and only include those. What's nice about machine learning is that because it's a probability-based modeling, we can really feel like we can include whatever it is that we think to be important or maybe not important, and whatever it is that we collect, and see what comes up to be as an important variable. And so from that perspective, it somewhat reduces the amount of bias that we introduce into the modeling. Can you tell me your second question again?
How does the model help you when new therapies become available or patients change in terms of their presentation? So, somebody in 1987, we wouldn't have done a certain thing, for instance, a craniectomy, whereas now we do something new that comes up in your treatment armamentarium. How does the model help you with that, or how does it change, or how do you account for that in your modeling?
That's an interesting question, and definitely something that I thought about. Part of the I wouldn't say problem, but part of the issue that we have, as you correctly mentioned, is that machine learning is extremely data hungry. There are a lot of variables that need to be determined when you're performing machine learning modeling, so you need to accrue a lot of data. And heart transplants don't occur every day, mostly because we have a lack of in terms of donor hearts that are actually available. So you end up accruing data over the course of a long period of time. To accrue 500 patients, it took us 20 years. And so as a result of that, you kind of have to maybe accept the fact that therapies have changed over the course of that time period. Perhaps the next step would be to identify some sort of sensitivity analysis with respect to if there's any that dimension of time, as in the time from time in therapy progression.
I think that's good. I think there are other treatments, for instance, chemotherapy for breast cancer or other stuff like that, that you can use this model for those things as well. So you've chosen a thing where we only do 20 patients a year, but there are other areas of medicine that you can apply this to. I think it's really great.
Thank you.
Thanks for your presentation. Well done, and thank you to your group for all the good work. Couple of questions. It appears, and I think the registry analyses show the same, that the early morbidity and mortality is really heavily front-loaded. Some of that is dependent on the preoperative status of the patient. Can you tease out, sort of the big game here? What are the really important things, as opposed to, all that other information that may be valuable, but isn't going to be the item that changes the decision-making for an individual patient? Were you able to look at that with your modeling? The second question is that interim phase between the acute and the late, things happen, and yet your study and others don't seem to look at that really. Is there a material there that could be addressed with respect to surveillance or interim management that may alter this scenario? Thank you very much.
Thank you for your question. Certainly, speaking to your first point, are there just like the top 3 variables or top 4 variables? Because there's something definitely lost from making things overcomplicated. And actually, if you will, I do have. So these are the trajectory plots actually are derived from these things called SHAP values. And so we can see here if you look on the left-hand side, so the early survival prediction, the SHAP values, basically, if you add them all up, will give you the final prediction value. To me, what was really striking here is that if you look at the top kind of 4 variables, the SHAP values are, greater than from what I can see here, 0.4, 0.5. And so you're right in the sense that really the outcome is dictated by, 4 or 5 variables, but what makes machine learning nice and what makes analysis like this nice is that you have, at a patient level, you're able to provide further granularity. So that is, for example, total ischemic time, though it's at the very bottom of that list, from a patient-to-patient basis probably does make a difference. And it would be relevant for us to be able to come down to that level of granularity. So on a population level, probably the top 4 variables are sufficient. But because we're doing, patient-level care and we only have 30 hearts a year to give, I think it becomes prudent and relevant to actually look at more than the top 4 variables. With respect to your second question about, I think that's a question I ask myself too, because you can create as many phases as you want, realistically, right? So you can say even within the first 30 days, you can break that up into the first 14 days and the next 14 days, for example. That is definitely something that I can look into. I think I broadly broke this up this way because, as I said, when we looked at the actual outcomes, we saw that 70% of patients died within the first 30 days, and then and also patients within our data set, patients that survive past 1 year usually survive for a really long time. So we felt as though those were the kind of 2, if you will, hot points that we really wanted to address. But certainly, I think you can break it up into multiple different phases.
That's great. Thanks very much. I think we'll move on to the next speech. So the next speaker is Mark Shafarenko, who is a third-year plastic surgery resident, and he took the 3rd prize in the McMurrich Prize category. And the title of his talk is Development and Validation of a Novel Augmented Reality K-Wire Fixation Simulator. Mark?
All righty, good morning. Thank you for the opportunity to present. Our disclosures are as follows, and the learning objectives for this morning are as stated. Now, in the ever-evolving landscape of surgical education and the transition to competency-based design, there is an increasing emphasis on residents to demonstrate procedural competency as a requirement for program completion. This is compounded by a framework of duty hour restrictions in which there's less time for resident skill as well as knowledge acquisition. We've also seen an increasing emphasis on patient safety and adverse outcome concerns. Taken together, this creates a challenging educational paradigm for resident development. Now, to combat this need, we have seen increasing use of surgical simulation combined with the use of virtual, augmented, and mixed reality. And broadly speaking, what these simulators aim to do is to maximize the transferable aspects of procedural skills prior to entering a true surgical environment. Now, in general, the goal of any surgical simulator is to develop a high-quality system to aid in trainee competency development while minimizing risk to patients and ultimately optimizing our resources as well as our patient outcomes. Now, virtual reality, or VR, can be broadly defined as a simulated digital environment that is completely isolated from the user's surroundings, and this is often accomplished with the use of a wearable headset. AR, or augmented reality, can be defined as digital information that is overlaid onto the user's field of view. However, it's important to note that this information is not actually interactive with the user. Mixed reality, or MR, on the other hand, involves the blending of virtual and real worlds, and this is fully interactive with the user. Now, the benefits of surgical simulation have been well established across multiple domains and multiple surgical disciplines. They include the acceleration of learning curves, proven benefits for resident skill development, as well as improved resident competency scores and operative performance in a clinical setting. Now, in the pursuit of an ideal simulator, AR and MR are likely to become the predominant modalities, given that they allow the integration of the visual information with the user, allow for integration of haptics and force feedback, and also provide the ability for remote learning and telementoring applications. More specifically, MR and AR allow the user to, again, avoid patient safety concerns and provide an environment for deliberate practice outside of a clinical setting. They have also been shown to reduce error rates by the user and provide for flexibility for the timing and location of training, as they can be readily deployed on multiple mobile devices, including iPads. Unfortunately, few models exist currently for plastic surgery trainees, particularly for procedures that are technically challenging and for skills that can transfer well into the clinical environment. Within the realm of plastic surgery, the procedures that are most likely to benefit are those that are technically demanding, require a high degree of visual spatial awareness, and where those where clinical opportunities may be limited owing to, number one, rarity or the potential for adverse outcomes. And one such clinical entity involves K-wire fixation for hand fractures. So this is a challenging task for novice learners as it requires a high degree of visual spatial awareness and planning. However, it's important for all trainees to become really competent with this technique, as it is commonly encountered in clinical practice. Now, unfortunately, few simulators and few clinically relevant models exist for K-wire fixation for resident learners, and therefore more robust models are needed. So existing infrared and optical, as well as electromagnetic tracking, which are widely considered to be the gold standard, are quite expensive and therefore require specialized equipment. Therefore, in the creation of an ideal simulator for K-wires for residents, we require a model that can not only clinically emulate the operative environment, but also can be widely deployed at a reasonable cost. And therefore, the objective of our study was the validation of an augmented reality tracking and registration systems against established optical or infrared and electromagnetic or EM tracking, all the while developing a hand fracture simulator that combines a physical model with an AR overlay and integrated AR tracking for independent components, including the hand, the fracture fragments, the K-wire simulator, as well as the K-wire driver. And we hypothesized that augmented reality tracking could be optimized to such an extent in order to provide comparable accuracy to conventional methods of registration and tracking in a model of hand fracture fixation. To do this, we first began with a 3D printed hand model. This was done using CT reference images of a healthy hand, and these images were then segmented further to create a base of thumb metacarpal fracture, also known as a Bennett fracture, which you can see depicted in the lower right corner. This was then 3D printed to create a rigid printed skeleton. The same model was then used to create a 3D printed negative mold, which was subsequently casted in silicone over the rigid printed skeleton in order to mimic soft tissue coverage of a healthy hand. Electromagnetic sensors were then inserted into the model, and infrared trackers or fiducial markers were also mounted onto the model at various coordinates. Respectively, the optical and the EM tracking systems were then used to co-register their respective sensors with the image target. The augmented reality tracking was then facilitated using Vuforia and the Unity AR development software, where a mobile device camera, in this case a Logitech C920 camera, can be used to estimate position based on edge and corner features of the image target. So measurements were then made between the AR tracking and the IR or the EM tracking, and all measurements consisted of XYZ coordinates in a three-dimensional grid. Measurements were then performed at working distances that were clinically deemed to be relevant, ranging from 20 to 35 centimeters in 5-centimeter increments. And correspondence errors between the two systems were then measured for the entire working volume. Ultimately, 7 position pairs were collected at each depth. And what we found is that rigid registration errors for both the IR and the EM systems were less than 1 millimeter across all depths of field relative to the AR camera. So in Table 1, we see the co-registration errors between the AR and the IR tracking positions. So we can see that there's a general trend towards an increasing mean error as the working depth increases, but ultimately, on aggregate, the mean error is still less than 1 millimeter. Table 2 demonstrates the co-registration errors between the AR and the EM tracking positions, and a similar trend is observed. As the mean error, or excuse me, as the working distance increases, the mean error is slightly higher, although in this case, the mean error on aggregate, once again, is less than half a millimeter. And here's a video depiction of what the model looks like in real time. So here we see the K-wire and the K-wire driver in situ. An important feature is the ability to toggle the opacity of the overlying skin, and this can be toggled depending on the level of the learner. In the top right, what you've seen appeared is the fluoroscopic imagery that closely mimics what we see in the operative setting with the fluoroscopy machine in the operating room. Now the two segments in blue demonstrate the 2 fracture fragments there. This is the base of thumb or the Bennett's fracture that we can see here. And ultimately the goal will be to position a K-wire appropriately and drive it into the trapezium depicted in orange. Now the red dot here demonstrates the ideal starting location for the K-wire. And what we can see here is the user trying to optimize the trajectory once the ideal location has been depicted. And again, this is all fed back in real time using the fluoroscopy imagery that we see depicted in the upper right corner. So again, further optimization is being carried out here by the user to try to get the ideal trajectory for the K-wire. And again, this is fully manipulated in 3 dimensions. And here we can see the user has locked in the appropriate trajectory for the K-wire fixation task. And then they proceed now with driving the K-wire in a retrograde fashion into the trapezium to complete successfully the K-wiring of the Bennett's fracture. And this is the complete, and this would be at the conclusion of the task where we see the fracture fragments adequately reduced and the K-wire in an adequate position. So in conclusion, we have been able to develop a novel augmented reality tracking system with less than 1 millimeter accuracy. And this has broad-ranging clinical applications, as we have essentially been able to eliminate the need for infrared and electromagnetic tracking, which are quite expensive. So by significantly cutting the cost for such a simulator, it makes it much more broadly accessible for residents across all levels, and therefore has much more impact on the ability for residents to successfully acquire these skills. The next steps involve optimizing our physical model and fusion with the AR overlay, as well as demonstrating efficacy against current teaching paradigms. And given what's been demonstrated in other fields, in particular placement of pedicle screws in neurosurgery and spine surgery, we would expect a high degree of transfer of these visual spatial skills into a clinical environment. Next, we would seek to create and validate objective performance metrics that could be used to assess residents on these simulated tasks, ultimately with the goal of more broad-ranging integration into CBD curricula. For instance, with the creation of standardized simulators, much like those that exist in general surgery, for example, as well as validated assessment tools, this is a much more objective way of tracking resident competency and progression over time, and ultimately assessing suitability for operating on patients in real time. Thank you.
Very nice presentation. Mark, we'll open this paper up for questions. Yes, first mic.
Hi, Mark. Thanks very much for the presentation. I was just wondering if the error of 0.5 to 1 millimeter, or the difference between the methods, is clinically relevant.
Yeah, so generally anything less than 1 millimeter is clinically acceptable, which is why we're quite pleased with the results of this, because it demonstrates that it can be translated into clinical practice with quite high accuracy.
And what might some of the limitations be to this AR approach for training?
That's a great question. Something we've given a lot of thought about, and something that's really been quite heavily discussed in other studies. So the first one would be, of course, absence of haptics and force feedback. So that's technically a drawback of really any simulators at this stage. And ultimately, unfortunately, not all simulators can actively replicate the lifelike human tissue. So we hope, number one, by adding the soft tissue and the silicone, that can help to, number one, mimic the soft tissue coverage of a hand. But ultimately, the goal of these simulators is really to really develop visual spatial skills and really transferability across multiple clinical settings, as obviously not every fracture will be a Bennett's fracture. But by generally getting the visual spatial skills down, we hope that this can translate into a clinical environment, but haptics would be really the major drawback. Another drawback that is sort of unavoidable in some settings would be things like inattentional blindness. So if the user, for example, is wearing a AR headset, like a Microsoft HoloLens, they may be not able to detect certain errors within the surgical field, but that's also a work in progress with multiple groups.
Mark, thank you very much for a wonderful presentation. I just want to warn you that they asked a pediatric surgeon to be one of your discussants, and I can't comment on all the interesting technology you have. My question revolves around validation, because in the title you talk about it being validated, but then in your conclusions you talk about validation being the next step. In the title, when you talk about validation, what elements of validation are you talking about for this as a model?
Yeah, so it'll be basically trying to optimize our algorithm to more accurately track the various fracture fragments, and then further extension or validation rather in other clinical settings. So this is just the base of thumb metacarpal fracture. We have validation in progress for other hand fracture models, so multiple metacarpal fractures, for example.
Okay. Because my big brotherly advice to you would be to get some of the people from the Wilson Center Educational to give you some advice about validation. As somebody who's tried to publish a lot on this, the metrics for validation, I mean, it's dizzying, the numbers between face validity, content validity, construct validity, all the validity levels, that you really need some guidance. Because as soon as you use the term validity, all that literature comes from the psychology literature, and the application to surgical and psychomotor and technical, it gets kind of tricky, especially now that they've raised the bar in terms of we can't comment on having accomplished that until people are aware of the stakes of what they're being tested on. So I think what you're doing is fantastic. I'd be really excited as an educator, but find some people who are doing this just so you don't get being like a dog chasing its tail, trying to figure out what you're trying to validate and how to validate it.
Thank you.
You're welcome.
The pictures are amazing. The videos showed are amazing, very high fidelity things. I've never seen a fluoroscopy with that much fidelity. Do you think you're going too far? In other words, you do it at 360 and all that kind of stuff. I think it's great for education. I really do. I'm not joking. But I think sometimes the level of detail you guys show us is different than we see clinically. And do you think that we're going a little bit too far for that?
No, I don't think so. I mean, I think you want to maximize the visual input and the visual cues for a resident learner. And I mean, I think particularly with K-wiring, it's a very three-dimensional task. And I think as junior learners, speaking from personal experience at least, we often see the fracture in two planes. And I think really with expert instruction and being able to manipulate the fracture fragments in a hand in 3 dimensions, which we visualize with the C-arm intraoperatively, I think that actually third dimension is really critical, because often we look, or we may drive the KOR in, and we see that our alignment is actually quite good in, for example, the AP and the sagittal plane, but in a coronal plane, our alignment's totally off. So that third dimension and the third visual input, I think is absolutely critical for proper skill development.
I've never put a K-wire in, so I'm speaking from a different point of view.
Yeah.
Does it look like it does on a fluoroscopy? In other words, are you going too far? Then all of a sudden, you're going to have all the residents doing beautiful stuff on your model, and then when they go to the OR, they say, well, that's not the way it looks. I can't do it on the hand. From a learner point of view, from a teacher point of view, I'm wondering about that. And that's from somebody who's never seen a K-wire put in. But I do use fluoroscopy, and I know the difference between fluoroscopy and these pictures that the companies always show you about how to put in their devices. It's just a comment.
Yeah, so I mean, I think we've achieved a pretty good degree of realism in terms of what the fluoroscopy output can be projected back to the user, and it closely mimics what we see clinically. And again, in the video, we demonstrated the ability to toggle the opacity of the overlying skin envelope. So what we envision for the model is, number one, in a training scenario, you can have a fully transparent phantom like we had depicted there driving the K-wire. And then as you progress, that can be in a teaching mode, and then as you progress into a testing mode, that opacity can be turned all the way up to make the hand model completely opaque. And therefore, you actually rely a lot more on the fluoroscopy image and the visual spatial skills that you've learned from the model in order to be able to complete the task effectively.
Mark, I've put in a K-wire or two, and one of the things that I find is the biggest learning curve is the tactile feedback of what the wire feels like when it's in the bone versus the soft tissue. So in your model, are they executing this on a physical model that's going to give them that feedback?
So it's a handheld, so we actually have a physical hand model, a physical K-wire driver, and then the actual driving of the K-wire is done in a simulated fashion. And again, it is unfortunately limitation, but again, the goal is really the emphasis on transfer of those visual spatial skills.
Right, so there's no tactile feedback.
Not as of yet, but it's something we're working on, yeah.
Okay, great. If there's no, sorry, do you have an online question? Yeah, online question. If you're online and you want to ask your question, you can go ahead. Okay. All right, great. Great presentation, Mark. Thank you very much. Okay, our next speaker is Maria Popkov, who is in the first year of her master's at IMS. She's taken the second prize for translational research, and the title of her talk is Low-Dose Aspirin and Rivaroxaban Combination Therapy to Overcome Aspirin Non-Sensitivity in Patients with Vascular Disease.
Okay, so hello everybody. Oh, I have to talk here. Hello everybody, my name is Maria. Today I will be talking about low-dose aspirin and rivaroxaban combination therapy to overcome aspirin non-sensitivity in patients with vascular disease. To start off, I just wanted to ask if you can raise your hand if you know anybody who's taking baby aspirin, so the 81 milligram dose. Okay, thank you. So quite a few people here. So were you aware that aspirin resistance affects 1 in 4 patients? Oh, I forgot to press them. So aspirin resistance affects 1 in 4 patients with vascular disease. And aspirin resistance refers to the inability of low-dose aspirin to reduce platelet production of thromboxane A2 and thereby platelet activation and aggregation. So from a pharmacokinetic perspective, this can happen due to insufficient aspirin reaching the platelets, and the reasons for that involve inadequate dosage, poor drug absorption, or increased platelet turnover. From a pharmacokinetic perspective, this may occur due to aspirin not being able to inhibit the COX-1 enzyme, and that's due to a genetic polymorphism absorbed in that enzyme. So why should we all care about aspirin resistance? Why is that such a big problem? Well, that's because patients who are not sensitive to aspirin have a 4 times increased risk of major adverse cardiovascular event or major adverse limb event when compared to those who are aspirin sensitive. By MACE, I'm referring to heart attacks, strokes, or cardiovascular-related deaths, and MALE refers to progression to chronic limb ischemia, need of bypass, graft, or stent, and minor or major amputation. So the COMPASS trial was a recent study that investigated the use of combination therapy in clinical practice. Just a little over 27,000 patients were randomly assigned into one of 3 groups. The first group was 2.5 milligrams of rivaroxaban twice daily with 100 milligrams of aspirin a day. The second group was just the 5 milligrams of rivaroxaban twice daily, and the last group included just the 100 milligrams of aspirin once daily. So the study lasted 2 years, and the results indicated that the rate of primary outcome was lower by 24% in the combination therapy group than with aspirin or rivaroxaban alone. However, one of the things they did see was that there was an increased risk of bleeding in the group that had the combination therapy. Specifically, the increase of bleeding was in the GI. So the potential for combination therapy to reduce cardiovascular events has been demonstrated by the COMPASS trial, but the ability of combination therapy to overcome aspirin non-sensitivity is yet to be investigated, which is exactly what was the aim of our study. So we started off with phase 1, the discovery phase. Here we recruited patients with peripheral arterial disease taking 81 milligrams of aspirin daily. The patients were recruited from the St. Mike's Vascular Inpatient Clinic, and our exclusion criteria was as follows. So the patients were taking either another antiplatelet drug, taking an anticoagulant, had a history of bleeding disorders, gastrointestinal bleeding, thrombocytopenia, anemia, leukopenia, pregnant, or under the age of 18. So upon a recruitment, we asked for medical history and demographic history. That is summarized in the table on the right. So a total of 83 patients were recruited for this phase. And aside from the medical history and demographic history, we also obtained 3 sodium citrate tubes for blood to conduct platelet aggregation testing. I know this looks a little complex, but I'll walk you through it. So to assess platelet aggregation, the gold standard was used. That was the light transmission aggregometry. I'll be referring to it as LTA from now on. In short, this machine functions based on the principle of how much light passes through the cuvette, and with the help of centrifuge, we were able to produce platelet-rich plasma, or PRP, and platelet-poor plasma, the PPP. So platelet-rich plasma has high concentrations of platelets in it, and therefore plasma is cloudy and turbid, which reduces the amount of light that can penetrate through it. Therefore, the PRP is set as the minimum of light transmission, and by the same principle, PPP has low amounts of platelets, and therefore a lot of light can penetrate through it, and that is set as a maximum. So the second step is to add the drug of interest. So the second step is to add the drug of interest into the cuvette while it is steered with metal stir bars. Then the incubation period for 15 minutes begins, and after the incubation, an agonist of interest is added. Since the light transmission is directly proportional to platelet aggregation, as the aggregation proceeds, the light transmission through the cuvette also increases. And antiplatelet drugs should reduce the aggregation. Hence, if the light transmission is increasing instead, then the drug is not working well and the platelets are still aggregating. So the standard that we use with aspirin non-sensitivity is that if the final transmittance of light is above 20%, then the patient is not sensitive to the 81 milligrams of aspirin. Another cool, part of this equipment is that we're able to test multiple cuvettes, so there's 4 spaces, and at the same time we can analyze different medications and different concentrations at the same time. Oops. Okay, so with the use of this LTA equipment, we were able to identify that out of the 83 recruited patients, 64 of them were sensitive and 19 were not, which is roughly the expected result. About 20 to 30 patients are non-sensitive to aspirin. So when the 2.5 milligrams of rivaroxaban was added to the 81 milligrams of aspirin, then 8 patients were still non-sensitive, but 11 of the 19 who were originally non-sensitive now became sensitive. So therefore, this phase of the study suggested that the addition of 2.5 milligrams of rivaroxaban helps overcome aspirin non-sensitivity in 58% of patients who were originally non-sensitive to aspirin. Then the second phase of our studies was the validation phase. Here we recruited patients with also PED, but these were patients who were not taking aspirin. So the exclusion criteria was quite similar as with phase 1, except here we're looking for patients who are not taking any antiplatelet or no anticoagulant at all. So again, we asked for the demographics and the medical history, and a total of 58 patients were obtained in this part of the trial. So remember when I told you that the LTA is advantageous in the sense that it allows us to test multiple drugs at the same time in multiple concentration. So here we use that to our benefit, and we tested baseline aggregation with no drugs added at all. Then the second cuvette contained platelet-rich plasma with 81 milligrams of aspirin. The third cuvette had 2.5 milligrams of rivaroxaban, and the last one was both aspirin and rivaroxaban. Oops. Okay. So compared to the baseline, when nothing was added, when rivaroxaban was added alone, it did not significantly reduce the platelet aggregation in response to arachidonic acid. And then on the lower right side, we see that when the aspirin was added alone, the maximal light transmission did decrease, but in the presence of aspirin and rivaroxaban, this decreased even further. So these results demonstrate that 2.5 milligrams of rivaroxaban significantly inhibit arachidonic acid-induced platelet aggregation in the presence of aspirin compared to its absence. So to summarize, the combination therapy of 2.5 milligrams of rivaroxaban and 81 milligrams of aspirin helps overcome aspirin non-sensitivity in 58% of patients who were originally non-sensitive to the aspirin dose, and 2.5 milligrams of rivaroxaban significantly inhibits arachidonic acid-induced platelet aggregation in the presence of aspirin compared to its absence. And lastly, there are combined effects between aspirin and rivaroxaban on platelet aggregation. So patients who are not sensitive to aspirin may benefit most from this dual therapy, as the COMPASS trial has shown that rivaroxaban plus aspirin reduces adverse cardiovascular events, which we know non-sensitive patients are a higher risk of, and it would likely have a lower risk of bleeding in non-sensitive patients, as these patients have overall higher baseline aggregation compared to sensitive counterparts before initiating any therapy. Thank you so much for your attention.
Excellent presentation. I'll open up the mics for questions on this paper.
Hi, Catherine Howe from UHN. Very, very nice talk. I am a vascular surgeon, so full disclosure. First question stems on really why you think the rivaroxaban does that. It's a 10A inhibitor. Is there something that you know about the mechanism of action, even sort of when it's not well described, that would explain what you're seeing?
Yeah, so that is definitely an answer we don't fully understand, but we can speculate that rivaroxaban interacts with the COX-1 indirectly. There's no current evidence, but that is a speculation that can be made. Another thing is that previous studies suggested that patients non-sensitive to aspirin have residual COX-1 activity and TXA2 production, which may be one of the causes of increased platelet activity and thrombic risk in these patients. So perhaps the rivaroxaban is reducing the thrombin-induced arachidonic acid release and preventing the conversion of TXA2 from COX-1. But again, that's it's speculations made at this point. It's unfortunately difficult to to identify the direct mechanisms of the additive effects seen.
You're well prepared. One more question for you though.
Yeah.
It's a bit sneaky because I think Mo's working on this in his lab. But one of the things you pointed out is the fact that we actually have a high number of patients that are aspirin non-sensitive. That's a big issue. We run blind in vascular all the time, in my opinion, around antiplatelet recommendations, unlike maybe some of the other specialties that have been a bit more, or at least attempted to be more precise about it. Is there some plan that you guys are working on to try to help identify in clinic a way to know which patients are aspirin non-sensitive and therefore might be the key ones to be targeting for this second agent to be added?
Right. That's a very good question. Unfortunately, the techniques that are available right now are the ones that require very, very specific, training. And so it takes me an hour to do the LT, and it has to be done right after the blood is being taken. So there's no quick and easy method to this, unfortunately. Hopefully that is developed in the future. But so far, as of now, our research is focused more so on actually personalizing patients in vivo with the adjusted dose of aspirin, because as I mentioned earlier, also the one plausible reason why aspirin non-sensitivity occurs was due to the lack of aspirin, the low dose. So maybe some patients would benefit from a higher dose, which is exactly what we're trying to figure out now. And actually, when we increase that dose from 81 to either 162 milligrams of aspirin or even 325 milligrams, we see that that percentage of aspirin non-sensitivity, so it becomes more so about 80 or 90% of patients who were previously non-sensitive to aspirin are now sensitive. So it's significantly higher percentage of people than seen with the low-dose aspirin and low-dose rivaroxaban. So maybe there's some, some future going on here with the adjusting dose of aspirin alone.
Yeah, I've seen some of his data. It's really nice. Last thing, those 58 patients that weren't on anything, are they now on something? Did maybe talk to Mo about it and just make sure? I assume that there's some advocacy there.
Yeah, I personally don't know. We haven't been following up with them. I can look into that if you're curious.
Well, just making a simple
Thank
point.
you.
Thanks very much, Maria. So the final speaker for the morning is Jean-Jacob Brassard. He is a PGY3 in vascular surgery, and the title of his talk is Long-Term Outcomes of Endovascular and Open Surgical Revascularization for PAD, a population-based retrospective cohort study, and he's taken the second prize for the Surgeon Scientist Training Program. John?
Thank you for the opportunity to present our work pertaining to the long-term outcomes of endovascular and open surgical revascularization for peripheral artery disease. The interventional treatment of peripheral artery disease can be accomplished using endovascular modalities, that is, using angioplasty balloons with or without stenting, or with open revascularization, meaning with endarterectomy procedures or bypasses. Randomized data comparing the two modalities is sparse and is actually limited to one published randomized control trial. It's the BASIL trial, which was published in 2005. It showed that after 2 years, there was a significant benefit of open revascularization to prevent death or major amputation, as well as mortality. However, since the trial was published, there has been a significant improvement in the array expertise, as well as in the use of endovascular modalities, to the point that we most believe that it's not longer representative of contemporary practice. In fact, many people have started to adopt an endovascular first approach and have challenged the notion that open revascularization results in better and more durable long-term outcomes. There are some ongoing trials about contemporary practice, but these will be published in several years and may be of limited external validity. And they will also provide only limited insight on long-term outcomes. Looking at real-world literature, there is lack of long-term data as well, and the literature is also subject to coding inaccuracy as well as to residual confounding. So there is clearly a need to clarify the ongoing equipoise pertaining to revascularization for peripheral artery disease. So with that in mind, we decided to compare the long-term outcomes of endovascular and open revascularization for PAD. We performed a retrospective population-based cohort study using Ontario Healthcare Administrative data that is maintained by ICES. We used inpatient as well as outpatient data to find all revascularization for peripheral artery disease. The cohort of interest included all Ontarians at least 40 years old that were revascularized for PAD between April 2005 and March 2020. The exposure of interest was the revascularization approach, which was divided between open and endovascular, and was identified using a validated published algorithm by our group. Outcomes of interest included the primary outcome was amputation-free survival, which was defined as a composite of death or major amputation. That is an amputation that happens above the ankle. Secondary outcomes included major amputation, death, major adverse limb events, which is a composite of major amputation or reintervention for peripheral artery disease, as well as major adverse cardiovascular events, which is a composite of death, myocardial infarct, or stroke. Covariates were numerous and included demographics and comorbidities, as well as procedure and surgeon characteristics. For the analyses, we performed propensity score weighted time to event analyses. We first started by defining our propensity score using all the covariates that we've measured and accounted for hospital level clustering. We then calculated weights using overlap techniques. This is an innovative technique that tends to put more focus on patients that have the greatest clinical equipoise. We then went on to perform the time to event analyses. For the outcomes of death, major adverse cardiovascular events, and amputation-free survival, we used the Kaplan-Meier estimation technique in order to estimate the survival function and use Cox proportional hazards model to compare the two modalities. For the outcomes of major adverse limb events and major amputations, since death is a competing risk, we estimated cumulative incidence functions, as well as used cost-specific Cox proportional hazards model in order to account for the competing risk. We then went on to perform subgroup analyses of clinically relevant groups, including people with diabetes, tissue loss, which is the most severe presentation of peripheral artery disease, as well as those who underwent infrainguinal revascularization only, in order to get a cohort that closely mimics the one from the Basel trial. There were more than 28,000 patients that were revascularized within the time window. 39% of those patients were revascularized with endovascular modalities, 50% had diabetes, 63% were revascularized for infrainguinal disease, and 17% had tissue loss. The median time to follow-up was 4.42 years, with a maximum of 16.34 years. When we performed the weighting based on the propensity score, we achieved exact balance on all covariates, and this is in keeping with the characteristics of overlap weighting, which systematically achieves perfect balance for the confounders that are included in the propensity score. Before weighting, endovascular revascularization was more frequently performed in older individuals. It was also more frequently performed in individuals living in areas with greater ethnic concentration. Open revascularization, on the other hand, was more frequently performed in male and people living in rural areas. When looking at comorbidities in previous procedures, endovascular revascularization was more frequently performed in people with congestive heart failure, those living in areas where the regional smoking rates were lower, and as well in people with diabetes and chronic kidney disease. Open revascularization, on the other hand, was performed, last thing is they had a higher frailty risk score. Open revascularization, on the other hand, was more frequently performed in areas where the regional smoking percentages were the highest. When looking at revascularization characteristics, endovascular revascularization was performed more frequently in the later years of the study relative to the earliest ones. It was also more performed for tissue loss than open revascularization. Open revascularization, on the other hand, tended to be more scheduled and was performed more frequently in earlier years relative to the later ones. Finally, when looking at physician characteristics, endovascular revascularization was performed more frequently by surgeons that had a higher volume in the year preceding the event. It was also performed more frequently by younger surgeons who were earlier in their practice. Open revascularization, on the other hand, was performed by surgeons who had lower volumes in general and also who were later in their practice. Now, when looking at our primary outcome, amputation-free survival, we can appreciate here that endovascular revascularization was associated with an amputation-free survival advantage with a hazards ratio of 0.94. When looking at the secondary outcomes, there was no significant difference in major amputation, but endovascular revascularization resulted in an advantage overall for survival. When looking at major adverse limb events, early major adverse limb events, so before 4 years, there was no significant differences between the two groups. Following 4 years, there was an association between endovascular revascularization and decreased incidence of major adverse limb events. For major adverse cardiovascular events, there was no significant difference between the two groups. When looking at the subgroup analyses, overall, there were no statistically significant differences for any of the outcomes among any of the subgroup, except for late major adverse limb events, which tended once again to favor endovascular revascularization. This is not the case, however, in diabetes, where there was no significant difference. So the first important finding of our study is that endovascular resulted in improved amputation-free survival in the full cohort, and that there was no difference in when looking at the subgroups. This is an important finding because it directly clashes with the advantage of open revascularization that was seen with the Basel trial. It could signify that improvement in the use of endovascular technologies has resulted in endovascular modalities at least reaching similar outcomes to open revascularization. The same goes with a major amputation where historically open revascularization was associated with improved major amputation. In our study, there was no difference, and again, this speaks to the fact that endovascular modalities have gotten better over time, most likely. The same goes for early major adverse limb events, whereas there was no difference between the two. The third most important finding is that endovascular revascularization was associated with a lower likelihood of male in the later years, We do believe, however, that this finding warrants cautious interpretation, because in the longer term, it's really hard to tease out if a repeat procedure is related to the actual initial procedure, or if it's related to progression of the disease, or if it was done, for example, in another area of PAD. So the take-home message from this is that open revascularization may not provide superior long-term outcomes relative to endovascular revascularization. And this study, which uses innovative statistical techniques and very long-term follow-up, adds to the increasing body of literature that challenges the notion that open revascularization is a gold standard for improved outcomes. It also provides some context for the upcoming randomized control trials. Thank you again for the opportunity of the podium.
Very nice presentation, John. We'll take the first mic.
Sure. James Jung from St. Mike's. Congratulations, first of all, to you and the co-authors for this excellent paper.
Thank you.
This is a population-based comparison of long-term outcomes of endovascular and open revascularization for peripheral artery disease. Compared to the Sentinel findings in 2005, you demonstrated that there's an improved outcome, major outcome at the endovascular. This likely highlights the improvement in technology, surgeons, and patient samples. So my questions to you, number one, is what were your strategies to adjust for the location of the peripheral artery disease and the extent of it, because I'm not a vascular surgeon, but that seems like a big confounder. Number two is, did you see any difference in the outcomes based on the year of operation? Were there improvements as the surgeon experience increased? Thank you.
Thank you for two excellent questions. The first one pertaining to disease location, to the anatomy of the disease. We included infrainguinal disease as one of the confounders. Infrainguinal disease is a surrogate, an imperfect surrogate of where the disease is located. Unfortunately, the administrative data is quite limited in terms of what we can tease out in terms of the anatomy. We can't know exactly what the inflow is, what the outflow is. Again, very important parameters that we could not perfectly account for. Now, the second question about looking over time. We have not performed stratified analyses based on time. What we did, however, is we used the year of revascularization as a confounder inside our models as an attempt to try to shape how change in practice could have influenced the outcomes.
Yes, Jean, very nice presentation.
Thank you.
I think the Basel trial, or not the Basel, but the best CLI there in the final stages, so we may see it within the year. Can you tell me, in your study, how do you account for repeat interventions? Because in endovascular, as well as in surgical interventions, you know, some people thrombose their grafts, they go back to the operating room, and some people, you discover after they've had an endovascular intervention that they still have a critical lesion and you've got to go back. So they're in both groups, there are re-interventions. Were they different between the two groups? And were there a large percentage that required re-intervention in both groups?
If I understand correctly, you're referring to interventions before the event we used as the exposure for our study?
No, in other words, some of the patients would have an endovascular as opposed to an open intervention, but both would have a re-intervention rate. Were the re-intervention rates different between the two groups, or were they about the same?
I see. We did not specifically look at reintervention rates per se. We really just combined them with the major amputation as major adverse limb events. I can't really comment exactly on the rates of reinterventions only between the two groups.
And do you think that, statins, other interventions, were you able to look over time at the difference in pharmacological interventions in this cohort?
Very good question. We did look at medications that they were taking within a specific time window before their surgery. We did not include those in our propensity model, the reason being they're imperfectly captured within administrative data. Anyone below 65 years old is not included within the OHIP coverage, so they're not going to be captured by administrative data. What we did do, however, is we did a sensitivity analysis where we looked at how those were balanced in people that were above 65 years old. We found that they were adequately balanced using a threshold of 0.1 for standardized differences. Now, how those might have changed over time, we did not look at that. That would require very complex analyses using time-varying covariates, something we did, something we thought was maybe too complicated for the message we were trying to make.
Thank you.
Yep. Second microphone.
Thank you. I enjoyed the presentation as well. I wanted to ask you a question about the, using such a large data set to get perfect balancing. Obviously, the good thing is that allows you to really focus right in on the question of endovascular versus open surgery, which is the best. But on the other hand, I think I heard you say that, over time, things have been getting better, and yet the endovascular is more often done by young surgeons and people with busier practices. And maybe, is it possible you overdid it in that sense, that one of the ways that healthcare improves and evolves is that younger people adopt newer technology and actually do it well, and maybe there's actually, a variation between endovascular in the hands of old people, although they were the pioneers, no offense to Dr. Lindsay and others, in terms of introducing this technology, but it doesn't really become fully living up, even if you left the devices entirely the same. A young surgeon who is trained in that, certainly we see it in non-vascular surgery, people that learned laparoscopic surgery from their medical school days are much better technicians than people who tried to learn that later in their careers. So, did you overcorrect for this effective surgeon age and miss some part of that reason for the improvement?
We did account for the number of years in practice. Again, I mean, the reason for doing that, I think to your point, is not necessarily because we thought more experience from being older in practice correlated with better outcomes, but exactly that to control for the fact that training might have been different and in keeping with evolving technologies. I hope this partially answers your question.
That's great. Thanks, John.
Thank you.
Okay, so that concludes our morning e-poster session. I'd like to congratulate all of the e-poster winners with a round of applause. And Dr. Failings is going to make a few announcements to wrap up the morning session.
Great, thank you, and congratulations to all of the speakers. A special congratulations to Professor Peter Hutchison for a magnificent lecture. Dr. Aaron Now, thank you so much for your wonderful moderation of the morning. So just before we break at lunch, which will be at the back, just a special announcement, and I'll be calling on Dr. Robin Richards to also help me with this. So of course we're here to celebrate GallieDay, and I bet many of you don't know who Gallie is. So there's a picture of Dr. William Gallie, who was a brilliant and innovative a surgeon with multiple talents, and I think it's quite fitting that we celebrate the academic accomplishments of the Department of Surgery each year by honoring his memory. And he established the first organized surgical postgraduate program in the country, which has now been the model for Royal College training across the country. So in a similar sense, we also have had a tremendously innovative surgeon as our professor and chair for the last a decade. And Jim Rutka has been our McLaughlin professor and chair. He's a skilled and compassionate individual, a wonderful a surgeon, and a very innovative translational researcher, and his impact has been felt nationally and around the world. So we thought it would be fitting to honor Jim's tenure as our McLaughlin professor and chair to create the James T. Rutka Endowment for Research and Innovation in Surgery. I'm going to call on Dr. Robin Richards to tell us a little bit more about what this endowment fund will entail. And just while Robin is coming up, I'll just have you kind of read a few of these quotes, which will speak to Jim's tremendous impact in academics and in surgery.
Let's back up just a bit. Thanks, Michael. So the Jim Rutka Endowment for Research and Innovation in Surgery will support promising research initiatives across the department and its network of hospital partners and research institutes, capturing Jim's impact across many subject areas, including neurosurgery, global health, innovation, and physician wellness. The fund will also serve to unite our department by incentivizing and rewarding collaboration between scientists and clinicians located in different divisions, hospitals, and laboratories. The Rutka Fund is an endowment and will support generations of surgical faculty members and trainees, while also providing a lasting tribute to Jim and his legacy of leadership. I'm pleased to say that each member of the Department of Surgery's Executive Committee has made a commitment in support of the Rutka Endowment. And our support speaks to our admiration for Jim and our pride in the work that is undertaken by the Department of Surgery. Our support hopefully sends a powerful message to the larger community that our department's work and vision is worthy. I've been a vice chair for almost 20 years, and I've never seen the department in better shape. They say that we're third in the world, so if this was the Olympics, we'd be getting medals. So that's thanks to the department members, but also to Jim for leading. It's not easy leading physicians, and Jim does a great job. So I made a gift to the fund, and that's why members of the Executive Committee and Senior Advisory Committee have also joined me in pledging their support, because we think it's a very worthy endeavor and to recognize Jim's leadership. And we invite all members of the Department of Surgery community. My personal hope would be that everybody contributes something to join us in supporting the fund. Additional support will increase the fund's impact and benefit more deserving surgical research and innovators. So in the coming weeks, we will send you additional information about the fund and how you can participate in our efforts to honor Jim. So this is a slide of Jim with Ukrainian trainees. So together we can pay tribute to a remarkable leader and support tomorrow's brightest minds as they seek out solutions to surgery's most pressing challenges. So I thank you for your attention this morning, and thank you again to the members of the Executive and Senior Advisory Committees for their leadership in launching this initiative. And last but not least, and most importantly, we thank you, Jim, for your great leadership of this department over the past 11 years. It's truly an honor to pay tribute to you. So thank you, and I hope everyone enjoys the rest of the day. Thank you for your attention.
Well, on that note, let's break for lunch, and we'll reconvene at 12:45 for our trauma symposium. Very good. Very good. Bit of a marathon for you in terms of moderation, so thanks for hanging in there. Yeah.
Thank you, Mike. That's great. We're off to a good start. Huh? Yeah. Thank you. I obviously was embarrassed. I didn't know this was coming. No, I didn't.
Well, good afternoon, everyone. Hope everyone had a nice, yummy lunch. I actually thought the lunch was pretty tasty. We had a fantastic morning, really enjoyed it, and I'm looking forward to this afternoon. And also welcome to the people who are online as well, and thank you for joining us virtually. So, as I indicated this morning, and as evidenced by our Gordon Murray lecturer, the theme of today's GallieDay is focused on the art and science of trauma, and from cell to community. And I think the next four speakers really exemplify this. So I'll just introduce our speakers, and then we'll get on with our talk. So we have Mariam Fayez, who's a basic scientist in the Division of Anatomy. Barbara Haas, who's a surgeon. Gregory Harlock, who's an alumnus of our Surgeon Scientist Training Program at University of Manitoba, and Diane Nam from the University of Toronto. So the first speaker will be Dr. Mariam Fayez, who is a PhD from University of Barcelona in Spain, did postdocs in Gothenburg in Sweden, as well as with Anders Nage here in Toronto, and she's in the Division of Anatomy, and she's doing some really exciting basic science work on the role of astrocytes in brain injury and in disease processes, and she's a fantastic stem cell researcher. So her work will be on discovering astrocyte substrates in the healthy and damaged CNS, and discovering is also kind of a play on words with disco. So Mariam, over to you.
So thank you, Dr. Fehlings. I'm just going to try this out before I start. Okay, perfect. So thank you so much for the invitation to talk, and also just wanted to say thank you to Val and to Sylvia for organizing GallieDay. So as mentioned, I do very basic science research, so it's a bit of a change of pace. And today I wanted to talk to you about work that we do that's largely unpublished about discovering astrocytes, or the roles of astrocytes in the injured brain. Okay, so a brief introduction to astrocytes. Astrocytes are a type of glial cell in the central nervous system. And so, as many of you are probably familiar, glia is derived from the Greek word for glue. And kind of historically, astrocytes were just thought of these cells that would glue the central nervous system together, you know, in this world where neurons were king. But I think over the last 50 or so years, it's become quite evident that astrocytes might be the true stars of the central nervous system. So another nice play on words there. In thinking about astrocytes, you have to understand that astrocytes have very important roles in normal brain function. So they actually reside in very specific spatial domains where they can control thousands of neuronal synapses. Astrocytes can communicate. They do this via calcium signaling, and they're really important in exerting control over the neuronal circuitry. So astrocytes can release gliotransmitters, and they can recycle neurotransmitters. And then, of course, they have very well-established roles in the control of blood flow and water homeostasis. I think my favorite study about astrocytes was one where they transplanted human cells into the mouse brain, and it was suggested that astrocytes are actually responsible for making us smarter. So not only do astrocytes have really important roles in the uninjured brain or the healthy brain, astrocytes are really important after injury. And so astrocytes actually respond to injury in a process known as reactive gliosis, so the astrocytes become reactive. And they undergo a number of changes. So this can include changes in gene expression and hypertrophy. Astrocytes can proliferate, and if the injury is large enough or severe enough, astrocytes can actually scar form. But I think for me, the most intriguing thing about reactive astrocytes is their heterogeneity. So it's pretty well established that astrocytes are kind of a diverse population of cells with documented differences in things like gene expression, phenotype, and function. But I think with the boom in RNA sequencing, it's really become clear that, within this broadly defined group of cells called astrocytes, there are a number of diverse cell types and cell states. And so for this purpose of my talk, I'm just going to define diversity or heterogeneity as a diversity in both cell type and cell state. And so over the last number of years, I think what's been really neat is that a number of studies have come out showing that there is a high degree of transcriptional diversity in reactive astrocytes. And probably the most famous one of these examples was the A1A2 classification that was proposed by the late Ben Barres and his trainees. So these A1 cells, or these A1 astrocytes, are thought to release a lipid that can kill neurons. But there are a number of different examples of different types of astrocytes or reactive astrocytes, and another one is a specific type of reactive astrocyte that's found in the mouse model of human multiple sclerosis. So it's important to recognize that a number of variables actually influence astrocyte heterogeneity. The first one can be the severity of injury. So as clinicians, you guys are all very familiar with this. But I think it's just worth remembering that astrocyte or reactive astrogliosis can be a graded response. So in really mild injuries, you might just see small changes in gene expression and hypertrophy, but as the injury becomes more severe, or in the cases of more severe types of injury, you can actually get things like proliferation and even scar formation. Another really important variable is injury stage. So it's very well known that reactive astrocytes are going to play different roles at different time points post-injury. So reactive astrocytes can do very different things in the acute versus the subacute versus the chronic stages. And so just one example of that, also very basic science, was from mouse models of attenuated reactive gliosis. And basically what these studies show is that, early after an insult or an injury, reactive astrocytes are really important for limiting the amount of damage. But in later time points, like more chronic phases post-injury, astrocytes can be very inhibitory to processes that are beneficial to CNS repair and regeneration. So what you can just appreciate here is in those mice with attenuated reactive gliosis, you have larger lesion volumes in the acute stage, that black bar versus the gray bar, but you can get enhancement in processes like neurogenesis, so the red bars versus the yellow bars. So given, this diversity in function of reactive astrocytes, we were really interested in understanding the molecular signatures of these injury-induced reactive astrocytes. Oh, gosh, sorry. Okay, yeah. And so with a really great team of collaborators, we attempted to address this question. And so, we recognize that the severity of injury is really important, so we chose to do these experiments in a mouse model that's very reproducible, so a reproducible model of ischemic stroke. And in this model, very simply, endothelin-1, which is a vasoconstrictor, is injected into the sensory motor cortex, and this produces a stroke-like lesion. So very basically, you get neuronal loss, but also very importantly for us, you see a response of these reactive astrocytes. We also know that injury stage is important, so we chose to study astrocytes at one time point post-stroke. And so we isolated astrocytes in the subacute phase, or day 14 post-stroke, by expression of a cell surface protein. And then what we did is we took these glass-positive astrocytes, and we sent them for single-cell sequencing using the 10x genomics platform. And so when we performed data analysis on cells from the stroke or the uninjured, or astrocytes from the stroke or the control brains, what we saw was this. And so if any of you are familiar with single-cell sequencing, if you see a UMAP plot like that, you think, what's going on? There's absolutely no differences. This looks like a big blob instead of really unique clusters. And so we decided to do a proportion analysis. And so what we could really quickly begin to appreciate is that while there were, the same states in both the uninjured and the stroke-injured brains, so the stroke-injured are the red bars and the uninjured controls are the black bars, what we could really quickly see was that there was actually a shift in the proportion of these astrocytes after injury. And so what this suggested to us is that astrocytes are really just shapeshifters, and what injury might do is just shift the population dynamics of these cells. So then we asked, where do these substates or different types of astrocyte reside in the stroke-injured brain? And I think this is where the data became really interesting. So we took advantage of a 10x Visium platform, which is a spatial transcriptomics platform. And what this allowed us to do was give spatial resolution to our single-cell data. So we basically took each one of those clusters, which you can see in D, and we mapped those back onto a Visium data set with spatial information. And what became really evident to us is that we could identify 2 unique clusters of cells, so proximal and distal astrocytes, by using spatial information. And so proximal astrocytes just because they're close to the injury site, and distal astrocytes because they're a little bit further away. So of course we asked, what makes these distal and proximal astrocytes different? And so we performed differential gene expression analysis on proximal and distal cells. We were able to identify a number of gene targets from our single cell data, and then what we did is we took those genes and we mapped them back onto our Visium brains. And so what was really neat about that is we were able to identify a number of unique target genes, so things like SPARC, ApoE, ITM2B, which I don't know if you can appreciate here, but you can see kind of the high expression by the red dots within the injury area of those genes. But we were also able to identify downregulated genes such as CLU, and you can appreciate that with those blue dots in that injured area. And so at the end of all of this analysis, and we don't have to go into any detail, is that we came up with a working hypothesis that these proximal astrocytes seem to be involved in synaptic formation and reorganization. And so then what we wanted to do was to study these proximal and distal cells a bit further. So we took advantage of a really cool, I think, game-changing platform that's been developed by Aaron Wheeler's lab at the University of Toronto. So it's a platform called DISCO, and what DISCO stands for is the Digital Isolation of Single Cells for Omics. So DISCO was initially developed for cultured cells, but now it's been adapted to work with ex vivo tissue sections. And so we like to call this NeuroDisco. So what NeuroDisco allows us to do is go into a tissue slice, pluck up a cell, and then send it for downstream omics. And so in this way, we can capture spatial information as well as cellular and molecular profiles of single cells. I think what's also really neat about NeuroDisco is that you can capture cells based on immunohistochemistry or transgenic reporters, so it gives you a lot of flexibility in identifying a cell type of interest. And so in this way, I think NeuroDisco really enables us to ask really refined questions using sequencing. And so we use NeuroDisco, to address this question of what's the difference between proximal and distal astrocytes. And so what we did is we captured these proximal and distal cells from the stroke-injured ex vivo tissue. And what you can just appreciate here in that circle is an image of a stroke-injured mouse brain that's been stained for GFAP, which is a marker of astrocytes. And then on the right, you can see 5 disco or NeuroDisco captured cells. And so in the 5th cell, what you can appreciate is that if you take a picture of the cell before the lysis, you can see the nucleus, and then after the lysis, the nucleus disappears. So we know exactly which cell we've targeted. So what we did is we took these NeuroDisco captured cells and then we sent them for downstream single cell sequencing. And what was really cool was that when we looked at the single cell transcriptomes of each one of these cells, so each column in this heat map represents a single cell, NeuroDisco was able to validate some of the targets that we had identified from our combined Visium Chromium approach. But what I really wanted to highlight, which is in yellow, is that NeuroDisco can actually be used as an independent discovery platform. So those bottom 3 heat maps are genes that we weren't able to identify with the combined transcriptomics approaches, but were novel targets identified by NeuroDisco. And again, these relate back to our hypothesis of synaptic reorganization by these proximal astrocytes. You guys are all probably familiar with the fact that transcriptomics and proteomics don't always or don't have to align. So another, I think, unique feature of NeuroDisco is that in addition to single cell transcriptomes, it allows us to look at single cell proteomes. And so if you remember, one of the genes that we found to be upregulated from our transcriptomic data sets was ApoE. And what we found when we looked at single-cell proteomes from these neurodisco-captured proximal and distal cells was that we were actually able to detect ApoE, the isoforms of ApoE, and also the accessory proteins of ApoE. And so this suggested to us, again, requires validation, but that these proximal cells might be involved in there's a role for lipid transfer in these proximal cells that might again be important for synaptic reorganization. And so, what I wanted to kind of show you was demonstrate how technology can be used to answer these really simple biological questions. And so we set out to, kind of identify how heterogeneous are astrocytes after a cortical injury. And what we found is that, a bit unexpectedly, astrocytes are kind of shapeshifters. So using this combined transcriptomics approach, we were really able to identify a proximal reactive astrocyte state in subacute stroke. And our hope is by using technologies like NeuroDisco and really understanding gene and protein signatures, we'll be able to better understand the role of these proximal astrocytes in subacute stroke. So right now our working hypothesis is that these cells have an important role in synaptic remodeling. But what I also want to highlight here is that with technology and with powerful technology, especially like NeuroDisco, what we can do is layer lots of different types of information to now create kind of encyclopedic entries of single cells. And so with this really, I think, big data, massive information, we can start to understand cells and molecules in a completely different way. And so just to talk a little bit about why NeuroDisco might be so important and help us understand cell type and cell state and the importance of that in terms of CNS injury and also designing new therapeutics for CNS repair. I just wanted to highlight a couple of other projects that we're doing with NeuroDisco. So one of the coolest ones is actually a collaboration between the Thalings and the Wheeler labs. And in this case, we're using NeuroDisco to study stem cell transplants and spinal cord injury. And so here, just pilot data, but what we're able to do is actually selectively remove STEM121 positive neural stem cells that are part of a transplant, and then downstream profile them using transcriptomics to understand what are the molecular profiles of the transplanted cells. But other questions that we might be able to address with NeuroDisco are, by capture of the neighboring cell next to the STEM121 positive cell to understand how neural cell transplants interact with the injured environment. I think another thing I just wanted to highlight at the end is that NeuroDisco also allows you to layer lots of different types of metadata. So if you wanted to start to answer questions like, how are functional outcomes related to cellular and molecular signatures, what you can do is perform behavioral tests on animals, then take cells from tissue from those animals, perform downstream omics on those cells, and then in a final data integration step, what you can do is relate those cellular and molecular signatures back to whole animal behavior. And so in this way, I think NeuroDisco and technology can be really powerful to help us understand central nervous system injury and repair. Okay, I know that was quick, but I just wanted to end with time for questions. So before I do, I just want to acknowledge members of my lab, really specifically Erica Scott, who was a postdoc in Aaron Wheeler's lab and is now shared between us, and she's really pioneered disco and NeuroDisco, and is really fantastic. And then, of course, all of the people that we've collaborated with on these projects, so Srijoy Tripathi, who's at CAMH, Scott Yuzwa, who's in LMP, and of course, Dr. Phalings, who you all know. So thank you. Okay.
Great, thank you. Beautiful talk. We have time for one or two questions. Dr. Rutka.
Miriam, thank you. And it's really interesting, the role of astrocytes throughout the brain in different conditions. My area of interest is brain tumors, and recently Michelle Manji's group showed really striking data published in Nature where glial cells and neuronal cells interact, and it's the electrical currents coming from the neuronal cells that actually stimulate and cause progression of the tumor cells that are astrocytes. So I think that's interesting. But in your work and your work with Michael, let's say with spinal cord injury, can you look at what happens at the site of a spinal cord injury with the glial astrocytic scar that develops and figure out, because that as I recall, is one of the main barriers for getting regeneration established. Is there anything you can do to look at that with these technologies and come to a determination of what astrocytes are involved in this process?
Yeah, I mean, I think that's the, oh, sorry, I'm so bad at this. I think that's the real power of this neurodisco approach, is that you can, you have the opportunity now to pre-select for cells. So you could use transgenic systems, you can label for astrocytes, different types of astrocytes, and then you can do analysis based on location, so proximity to scar, contribution to scar. But what's really neat, and I think blows my mind a little bit, is that you can not only take this astrocyte, but you can take all of the adjacent cells around the astrocyte, and then you could even layer on really unique technologies. Like there was one called Rabies-seq developed by Quintana's lab, where you can kind of trace cells and how they're connected to each other. And so you can layer all of that technology into the NeuroDisco platform and then start to understand cell-cell interactions and really begin to identify or understand, you know, cell relationships and outcomes. So yeah, I think that it's super exciting.
Dr. Howe?
Hi, thank you. That's phenomenal work, and the platform, you're right, it's probably a game changer, or already is a game changer. I work in atherosclerosis, and one of the things when you read around what I find is common amongst biological processes, this idea that cells seem to be living on a spectrum, this identity spectrum. And as you talk about being a shapeshifter, is there a way that you can think of the astrocytes where you can figure out at what point along that spectrum you need them to be driving the repair process, and then can you get to them at that point and stop it so that they actually behave and stay in that state?
No, I love this idea. So it links, we do a lot of cellular reprogramming as well. And so part of the reason for, you know, trying to identify these states was really, can we identify astrocyte substates that we can target for therapeutics? So, you know, in this moment, you don't really want like this substate of cell because it's doing something pathological or detrimental. You could just shift it and make it into something else or remove it. And I think that that is, you know, the next 10 years of science. So I'm really excited about that.
Beautiful.
Okay, sorry. So much excitement. Okay, thank you.
Okay, thank you very much. All right, so we're going to move along, and the next speaker is Dr. Diane Nam, and Diane is an associate professor at the U of T, and she's an orthopedic trauma surgeon at Sunnybrook, and she specializes in upper limb issues, and she's also a clinician scientist at the Sunnybrook Research Institute, and she focuses on molecular and cellular mechanisms of bone regeneration with a view to trying to facilitate fracture repair. And her talk is on fracture healing. How can we do better?
Thanks, Dr. Phalanx. And thanks for the opportunity to talk about fracture healing. As many of you know, if it doesn't affect you, if it doesn't happen to you, you don't really think about it. And, but you know what, about a third of us will actually get a fracture in our lifetime. And that's a lot of fractures a year. And if you think about it, while some fractures are life or limb threatening, majority of the fractures we sustain are usually, you know, take some time to heal, 8 to 24 weeks it could be, but it's a long time down. And even after all of that, it may not heal. And if that happens, it's a lot of work, not only on the healthcare and your orthopedic surgeon, but to you as well. So, you know, because it's such a common problem, and because it takes so much of your time, it is actually a significant burden. And, you know, we have to figure out how to do it better. So imagine this is your leg, and your tibia is broken. You got to see an orthopedic surgeon, he fixed it or she fixed it, and this is your 2-week follow-up. And you know, nothing's gonna heal at 2 weeks, so that's fine. But what about when at 6 months you come back and it's still not healed? You know, you've had 6 months of hobbling around, probably your life has come to a halt, you've lost time and money not working, and it's a significant issue. And I think when you think about all of the downtime and healthy, active adults that it's happening to every day, right now somebody's busting a bone. And they're going to show up at Sunnybrook most likely, but it's one of those areas where you really have to think, how can we bridge the gap in terms of ways to accelerate and to ensure fracture healing happens successfully, and then really understand what's the molecular and cellular process of bone regeneration overall. While we have an idea of what injury does to the body and to tissues, we actually don't know the intricacies of the cellular mechanism. And then ultimately, we want to bring some of that to the patient in clinically translatable treatments. So let's first talk about IL-17F. This is an interleukin, and there's so many, but interleukin IL-17F is secreted by T helper cells. So why the focus on the immune system? Well, we know that the immune system has a significant role in modulating the inflammatory process. And the inflammation process is what happens when we get injured. But how does that trigger and the mediators that come to the bone actually end up on successfully healing it? So we looked at the immune system and we tried to knock it out. So we actually looked at mice that were knocked out T cells and B cells. So these were completely immunodeficient rodents. And we broke their tibias and we assessed them compared to their wild type. And we found that the immunodeficient mice, the RAG1 mice, actually did have impaired healing. So you're not too surprised, but you can see that the callus, this is a micro CT, the bone is wider, it's less dense, it's really not healed. It doesn't look like your bone again. And we actually saw it at the molecular level as well. If you actually put in a fluorescent marker and after fracture and as it was healing incorporated the marker, you can see that on the wild type mice, you see these large gaps. Bone is being laid down between the green lines. But if you look at the immunodeficient mouse, really nothing is happening. And so that could be us in some situation if you have that element where the immune system is actually not communicating well or doing its job. So we actually figured out what was happening at the cellular level, and it was really critical and focused on T cells. So the adaptive immune response was found to be critically important in the mediation of promoting and increasing the proliferation and maturation of osteoblasts. Osteoblasts are bone-forming cells, and those are the cells that actually make bone. You can't do it when you're a pre, you can only do it when you're all grown up and you're a mature cell. And unfortunately, that doesn't happen, and we don't have lots of osteoblasts circulating all the time. So we found that when injury occurs, we get a pro-inflammatory response that pushes the mediators down this pathway. The anti-inflammatory response is suppressed, and the T helper cells are secreting IL-17F in the normal state to stimulate pre-osteoblasts into mature osteoblasts. Now, about the time that we were finishing up our research on IL-17F and kind of linking it to the inflammatory phase of fracture healing, we were also looking at lithium. And as you know, lithium is a safe and effective medication that has been in practice for over 60 years to stabilize mood disorders. However, not many of you may know that it's actually an anabolic drug that stimulates the Wnt beta-catenin signaling pathway. Now, the canonical Wnt signaling pathway is the main pathway in which the osteoblasts are triggered to actually start creating the mineralization or the calcium that's required to create bone. The thing is, nobody knew how to use it. It's lithium. How much do you use it? You know, if it was for mood disorders, it's about 1,200 to 1,800 milligrams a day, very close. The therapeutic dose and the toxicity dose is very close. So, you know, we didn't know how much, we didn't know how long, and when to even give it. So we took the preclinical model and actually figured out what to do. But I wanted to vary all three variables at the time. And so a design of experiments was actually used in this molecular biology setting. It's typically used in other settings and not more commonly in this setting, but we were able to actually determine what dose, how much, and how long all at the same time. And also, because it's such a statistically powerful tool, we were able to find some interactions. And we actually found that one of the three variables was actually the most predictive, and that was when to give it the onset. What we found out through our preclinical rodent experiments was that when we took a rat and we broke their femur, and they received lithium starting 7 days after the fracture, and we gave it for 2 weeks at a very low dose, we saw a significant increase in their biomechanical strength than the rats that didn't receive lithium. That's significant. If you think about the amount of healing that occurs, and it's solid, and it's stronger, you're going to be able to get moving and mobilize faster. All the other ones, the higher doses, the shorter time, all of the other factors and combinations were less effective. So this was really helpful, and I thought, well, if it works in normal rats, maybe we should try it on osteoporotic or impaired bone healing situations, because osteoporosis is such a huge burden in orthopedics for the elderly. So we actually tried it, and long story short, it does work. However, we had to modify it. The same regimen does not work in an osteoporotic situation, because as we know, patients with osteoporosis, their bones heal, but it just takes longer. So that timing of when lithium has to be given, remember I said the onset is the most critical factor, has to be slightly delayed. So instead of the 7 days, we gave it at 10 days, and we found that we had the same effects of at least 50% improvement in the biomechanical properties. So just taking all of that to consideration, I thought, well, now let's get out from the animals. Let's see if we can do it in people. And just because you can see here on the CT 3D rendered study, you can see the animals that have lithium, their bones look normal, and they're already healed. So at a certain point, it's actually further along in the healing process than those animals that didn't require it. So if we can actually use that in people, that would be fantastic. So what we did was we went on to get some initial funding to get a single center randomized control trial going. And so what we had to figure out was how could we actually make the human equivalent of what we saw in the animal studies. So we were able to figure out that the onset now in people had to be 14 days, and that the dose was a low dose. Remember, it's 12 to 1800 for our mood disorder. For bone, it's 300. It's almost nothing. And then the duration was still 2 weeks. And then we wanted to assess it through the primary outcome of bone healing, and we wanted to do it easy, because if we're going to be able to translate this, it has to be done with little or no trouble and not really change what we do in the standard of care, which is orthopedic surgeons, we look at x-rays and we see if there's bone on the x-ray, one right after the other. So affectionately called LIFT, lithium for fracture treatment, this study has now continued on. And what we found was our preliminary data. We unblinded a few patients, so about 10, just to see if it was worth continuing to pursue and asking for further funding, because recruitment in this trial was somewhat challenging, was that we actually did find that all of those patients that received lithium were healed. And you can see it's not statistically significant because it's a small number, but it was trending towards that. And then the pain scores were already significant. So patients on lithium actually had less pain than those that did not. And a lot of the common questions I get is that, it's lithium. Do you have any changes in your mentation? And we assessed that your mental scores actually didn't change at all. Now, again, these are preliminary data, but it gave us enough impetus to actually apply for multi-center funding. So we went ahead, and so we got the CIHR funded for a larger trial, and it's a 4-year trial that we're recruiting for now. It's 5 sites and a sample size of 160, and it's a short follow-up. It's 6 months. Why? Because at 6 months, if it's not going to do its thing, I might as well just pack up, right? So it's a good design. We can capture patients, but lithium still has a lot of negative stigma related to it because it's a psychiatric medication, so we've had our challenges. We wanted to look into the healthy cohort just as a proof of concept. So while I think it's going to work in healthy and osteoporosis, patients with osteoporosis are typically older and have a lot more comorbidities. And the drug interactions are, and when you're doing a drug trial, it's a little bit challenging. So we picked a healthy cohort, 18 to 55, healthy and with ASA class less than 2. And only certain bones were eligible because in order to actually score it, you actually had to have a certain type of healing, relative healing, not absolute. And it had to be a long bone where you could actually get 2 orthogonal x-rays and actually see the callus or the bridging callus from one side to the other. The radiographic measurement is key. When we look at x-rays, we want to assess if it's better from the last. And we can clearly use this RUS score that was reported in 2010. It's been validated and it's very reliable. And it's very easy to use. So, it doesn't have to be done in an academic center. It can be used anywhere around the world. So we now kind of took our focus, really confirming that lithium was acting at this stage where bone was being laid down, not at the inflammatory phase where the interleukin 17F was acting, but in the later phases of healing. And so if you look at it at the cellular level, what we did was we mapped out exactly what was happening in the osteoblasts. And the osteoblasts actually have IL-17F receptors. And it's simultaneously going on. So that has not been detected prior. We know it's in other cells, but we didn't know it was in osteoblasts. And so you have this kind of temporal regulation of what's going on in the osteoblast to kind of push everything down towards upregulating all of those genes that actually lead to increased bone formation. So we mapped this out and published our work here, and it really boiled down to two transcription factors, CEPB beta and delta. And actually, they were acting on one of the proteins that actually stimulate bone formation in different locations of the promoter. So you can see, if you think about the inflammatory process and acting on the immune-mediated portion of it, and synergizing that with the later portion of the reparative process, then we could actually get some action going. So this is just to summarize. If you look at it vertically from top down, hematoma, IL-17F, and the cellular effects in the cell directly towards its receptor, the IL-17F receptor. And then later on, it's going to continue. So when fracture healing is impaired, you can imagine that, you know, if both of them are good, you're going to have great outcomes. If one or both are impaired, then that may be why we don't heal. And as you know, not everybody heals, and you could be a healthy person without any risk factors, and you can still have about up to 10% chance that you might not heal your fracture. So while the clinical trial is now still recruiting, and we're looking for patients, we were thinking about other things that we can do. And you know, probiotics and the gut microbiota has been a huge topic, and it's not new, it's been around for many years. But how does it relate to bone? Well, we know that it increases osteoblastogenesis and proliferates osteoblasts. We know that it decreases osteoclast, bone resorption, and it increases the bone mass. But what does it do to fracture healing? Well, if you think about the gut and the complexity, there are millions and millions of microbes in our gut, and these microbes mediate T cells. I didn't know that, actually. And if you think about what the T cell, we keep going back to the immune system and how the local inflammation is modulated. It's, again, the battle between pro and anti-inflammatory cytokines. And you can actually trigger, some of these microbes are facilitating the resorption of key immune cells into the circulation that may have an end target, which is bone. So it's really critically important to understand, and it's so complex, it's not even something that we can just kind of say, oh, it's this bacteria or that bacteria. It's a family, a community of organisms that are acting in concert. So what we did was, well, let's try this. Let's take another preclinical model, and this time we took mice. We made two cohorts, and basically we had a prevention cohort and a treatment cohort. In the prevention cohort, what we did was, let's just give them probiotics for a few weeks and then break their bones and see what happens. And then in the treatment, we didn't give them any preload of probiotics, but we created the fracture and then treated them with probiotics. We found out that the prevention model had the greatest effect on modulating the fracture healing. It actually increased the bone, key bone genes, expression of gene markers, as well as increasing bone mineral density. And it also increased biomechanical strength of the bone. Now, the treatment cohort, it wasn't all a bust. It still worked, but it only had an effect on the mechanical strength. It didn't really have its effect on the cellular and the molecular level. And it makes sense, right? Because the gut flora, you just can't create it overnight. It has to be primed. So I think pre-treating with probiotics and getting your gut into a certain homeostasis and then creating the fracture most likely has that effect, not only at the bone level in terms of its healing, but actually at the cellular level. So I think if you actually added the two together, did it all the time, and then treated it when a fracture occurred, is probably where we're headed. So if you think about the microbiota, and I keep bringing back IL-17F T cells, you can see how things are starting to link up. And it's nice to know when you're doing research that things kind of make sense and follow a certain type of pattern. The T helper cells are key, not only in other aspects of the immune response, but really it's critical in bone healing. So if you kind of put the picture together now, we're at the stage where we're trying to now synergize the probiotics and the cytokines as well as lithium. And this is a schematic of what the osteoblast might look like with all of the receptors and the signaling pathways that's involved. So in summary, you know, we want to make it better. I think we are doing better. We still can't fully understand what the key assessments are, but really the things that we're talking about to accelerate and ensure fracture healing is more reliable. Well, we have IL-17F, we have lithium, probiotics. These are not expensive items. These are not dangerous items. We can manipulate them. We have a better understanding of the molecular and cellular process of bone regeneration, understanding that this two-phase temporal regulation exists. And of course, how do we bring that now to patients? So in addition to the LIFT trial that we're doing, you can see that, you know, in Canada, we're very spoiled. We have the best of everything. And if we can't get a fracture to heal, like, you know, it's tough. But what about in an underdeveloped country where, you know, road traffic accidents are rampant? You know, they don't even have the access to care that we do. A lot of them, if they have a fracture, they're bedridden for months, right? So the impact on a global scale for something that's so cost-effective, easily accessible, and easy to take and administer, I think has a significant impact. So we're kind of at that stage and hoping that we can continue to expand this. And I'd like to really thank my co-investigators. Carrie Wine has been really instrumental in helping us throughout the trial, and my tech, Yufa Wang, has been pivotal in all of the discoveries that we've made. Thank you.
Thank you, Diane. So nice example of kind of bench to bedside works. We have time for one or two questions.
Hi. Interesting talk, Diane. I want to ask you, where do you think the lithium goes? Does it go in the apatite lattice?
I'm sorry, I didn't hear that.
Lithium dose.
Oh, where did we get the lithium dose?
Yes.
So that was done when we did the design of experiments. We tested multiple doses at high and low and middle. And we found that with the design of experiments, the lowest dose had the best effect.
No. Where in the bone does the lithium go?
Oh, so that's an excellent question. So the lithium does get incorporated into the bone matrix, but it actually targets the cell. It's a GSK3 beta inhibitor, as you know, and once it's done, it's eliminated. So there's no retention of the administered lithium when we give it, and we haven't detected it actually in the bone cells, thinking that it would be there, but in our molecular studies, in our histology, it's not there.
Because some people have said that it may replace calcium in the apatite lattice of bone.
We haven't been able to confirm that.
Thank you.
Thanks.
Okay. Thank you very much, Diane. Okay, so our next speaker is Dr. Greg Harlech, and Greg is actually an alumnus of our surgeon scientist training program and the neurosurgical training program in Toronto. His PhD work was actually in animal models of spinal cord injury and kind of looking at the role of stem cells. And he's kind of evolved his practices and his interest in other areas of neurotrauma with a particular focus on traumatic brain injury. So he's a neurosurgeon at the University of Manitoba, and he's been very proactive nationally and internationally in the sphere of traumatic brain injury. He is involved with a group called Global Neuro that's very active in knowledge translation in neurotrauma. He serves as the medical director and chair of the medical advisory board of the Brain Trauma Foundation, and I think Greg is perhaps best known for his work around guidelines development. So Greg, I have to say your talk title is a bit controversial. So has neurotrauma been built on a faulty foundation? So over to you, Greg.
All right. Well, good afternoon, everyone. It's a great pleasure to be with you. This is a forum for which I have tremendous respect. And that's indeed what I wanted to do this afternoon is give a bit of a fun, in fact, a bit of a provocative talk, because I think the real challenge to my generation of neurotrauma surgeon scientists is trying to figure out why we aren't advancing. I've always liked the way that my mentor, Ross Bullock, conceptualized head injury. This is supposed to be Darth Vader and Luke Skywalker fighting. Really, our goal is to try and keep good brain from going over to the dark side. And the reality is that I don't think we've been doing this very well as neurosurgeons. Unfortunately, we really have seen a tremendous failure of TBI research. As Hutch alluded to, we've had over 20 late-phase clinical trials that haven't amounted to the translation of a single agent. I think more concerning than the trial failure is that we've seen a period of reduced research funding and fewer trials happening. In fact, I think Hutch is perhaps the only guy who's been able to move the ball down the field in recent years. It's not all doom and gloom. I think we have a lot of new tools at our disposal. I have to think that